I'd like to welcome you all here this morning, and as you're very much aware, we're here to not only listen to but honor one of the great ones of oral pathology, Dr. Bob Gorlin. As one of his old residents, I was asked to give a few introductory remarks, and I think it's probably a little superficial to do so because everybody in this room most likely has more than one Bob Gorlin story. Those of us who were his residents have many of them. And he's a man who's been respected by this group and groups all around the world for decades. However, I think within this academy he's also been loved, and certainly for his residents. That's probably the primary feeling that his residents have. It was such an honor and a phenomenal experience being a resident in Minnesota. There was never a time we didn't have people from around the world visiting. And we got to know those people, and those people became our friends as well. Bob is working on his new textbook, the latest edition of the Syndromes of the Head and Neck. I think he told me earlier yesterday that that will be coming out probably next year. The new edition of his hereditary hearing loss and syndrome book is also going to be out this year. I mean, I think his wife told me during his 80th year, he published 3 major papers, at least in his mind, major papers. I think most of us probably won't do that. He's received many honorary doctorates, most recently from the University of Copenhagen in November of 2003. And the people in this academy, of course, are very much aware of the fact that he won the Gold Medal Award from the American Dental Association because we sponsored that award. So, without any further ado, I think it's time to let the star come on board. I saw him here earlier. There he is.
The advancer. What happened to that? Don't know. Maybe it's back there. I got it in my pocket. Bad sign, bad sign. Now, does this work? Is this working? No. It is, okay. Well, I guess I have to go back one. No, I go forward one. Okay. Well, first I want to thank you all for having supported me. It was really a surprise. I did not know, in fact, that you had supported me for this ADA prize, but I'm now doing penance. Because with dear old Val, I am on the scientific commission that looks at such profound questions as remonstrance at dentists who are severing the tongue to make a bifid tongue. I didn't know that. Oh, is this something to do with this? Bim, bim, bim. No. Yeah, okay. Well, here, we can put this in here, I guess. I Googled it, and I looked up tongue splitting and found, in fact, that they attribute the first splitting of the tongue to an oral surgeon. So we do get our fame somewhere. I asked myself in such a presentation how I should approach this, and I thought that what I should do is give you an in to what's happening in genetics. One of the strange things that somebody mentioned to me a few years ago was that everything had been done now that the human genome had been sort of solved. And I said, my goodness, it's like looking at a book with no title. Well, maybe you could give it the title of life, I suppose, but which had no capital letters, no periods, no sentences, no paragraphs. In fact, no commas, no anything. And now we're gradually beginning to work out on these. But what I'm going to try to introduce you to during our 4 hours or 4.5 hours together is what has been emerging. And that emerging is the study of pathways. A quite remarkable book has just been issued by Oxford University Press. It came out, I'd say, maybe 4 months ago. And it is entirely on pathways. It's about the size of my 4th edition of Syndromes of the Head and Neck. And so all I can do is give you some idea of what is actually happening in the field. If someone were to have asked me when I went to dental school, if I thought that cells talk to one another, I would have probably thought for a while and not come up with many answers other than maybe the general concept of endocrine. That is, you know, some cells give off certain substances that we call hormones by and large, and these travel through the bloodstream for the most part and affect an organ at a distant site. But actually, it's the last two, that is the paracrine and the autocrine, cells talking to adjacent cells or cells talking to themselves. This chit-chat happens all the time, every second of the time. That's what happens. Well, now, how does this happen? I suppose I was introduced to this general concept at a remarkable time in my development. When I was a graduate student, well, I was never really a graduate student, but I was a student at Columbia, and I came into contact with a woman who had sort of pre-escaped the Holocaust. She came over in '31 with her husband, Willie, and Willie became head syphilologist of the city of New York, and Helen was treating prostitutes for venereal disease down in the Bowery. And Helen was a very famous dermatologist before she came, working with a fellow named Abe Bushke. And I had occasion to meet her when I was just sort of hanging out with the dermatologists because the residents all had to be prepared for their board. And one of the things they had to do is to learn a little bit of elementary things about syndromes. And they brought in Helen Kurth. And Helen talked about a condition that was, in her mind, very recognizable, but it wasn't a disease. It was a symptom or sign. Now, this is 47, so Helen was really remarkably au courant for her time. She realized first that it was a symptom, two, that it was associated with obesity and that it was associated with diabetes, and she also recognized that it had an association with syndromes, and one of her favorite syndromes with acanthosis nigricans happened to be the association with gastric cancer. Now, I was so amazed by this revelation because for me it was an apotheosis. I never had thought of things occurring in or around the mouth or on the face being associated with something as bad as gastric cancer. So I went up to Dr. Kurth and I said, Dr. Kurth, what do you call these? And she said they were syndromes. And I asked what that meant, and she said, well, Sinn means together, and Drom I forget. So I went out and I looked it up, and it meant run together. So I said, okay, fine. Now, I don't understand this condition. How does the presence of a tumor in the stomach caused the epithelium to proliferate. And she says there's some substance in this cancer, but it's causing the epithelium to proliferate at the expense of the connective tissue. So I said, what happens if the gastric cancer is removed? Will it disappear? I said, what happens if it comes back? Will it reappear? So I said, well, now what does that imply? That some signal is being given off by the cancer. Well, what is she talking about? She's talking about growth factors. Now, this is 1947. That's remarkable. And she describes some of these syndromes, like lipodystrophic diabetes, like the entity that Mike Cohen and I called cruzano-dermoskeletal dysplasia, that we'll show you a little bit later. She had just an amazing insight into these associations. Now, the general principle is as follows. You have growth factors, and that's that little triangle up there. The growth factor has to, the ligand, right, has to be the receptor. And that is a receptor up there on top of the cell. There's no pointer here, but that's fine. Then you see there has to be a, oh, okay. That's fine. Thank you. Thank you. Now I have to learn how to do this. Okay, now there is a signal transduction, bunch of substances. These are all sort of hung on the cytoskeleton. We'll talk about cytoskeletal disorders a little bit later, actin-binding protein disorders. And this may involve 1 or 2 or 3 or 4 or 5 or more signals that sort of chain down here to the nucleus. And then you have transcription factors that attach to the DNA or attach to the protein. And then RNA is manufactured and then translated into protein by the cell. But let's see how this works. Well, I made a list of just a few growth factors. And you know these as epithelial growth factors and fibroblast growth factors and etc. Okay. What we're going to do is just pick one of these, and that is fibroblast growth factor. And here you can see at the point at which I made this little table, there were 9 fibroblast growth factors, and some of them you already know about because, for example, some are oncogenes, the 3 and the 4, and others cause a branching of lung, salivary gland, and prostate. And of course, our ex-dean was working on a number of angiogenesis fibroblast growth factors, so-called basic growth factors. Now, these growth factors have to fit into these receptors, and they're on the surface of the cell. And here you can see an epithelial growth factor. These are insulin growth factors. And this is a platelet-derived growth factor. But the fibroblast growth factors have 3 interglobulin loops that stick up like aerials. This is the cell surface. And these are the protein kinases in the cytosolic area of a cell. So we're going to be looking at this group of entities. And here's actually, these are meant to be the 3 interglobulin loops. Here is your fibroblast growth factor. This is a little heparin sulfate, which is attached, and that is pretty much the way it is. You have your fibroblast growth factors floating around. They attach to the heparin sulfate. Then this comes in and attaches here. And these are the kinases down inside the cell. All right. because you can have mutations in any of these structures. And so if you put these on the side, you'll see that there is a fibroblast growth factor 1, a fibroblast growth factor 2, a fibroblast growth factor 3, and there is a fibroblast growth factor 4, but nothing is known about what it does. We know about mutations in all of the other conditions. Now let me tell you how it all got started. Back when I was growing up, there was a pretty good folk singer called Woody Guthrie, and he wrote a lot of songs that some of you may have sung. I don't know. Your land is my land. And he had a wife named Marjorie, and he had Arlo, his son, who sort of carried on for him. And then he had a daughter. Now, his mother, he knew, died from a neurologic disorder. And her mother had died from this neurologic disorder, so he wasn't the least bit worried. He thought that this neurologic disorder ran only in females, and since he wasn't, he felt he was pretty safe. Well, when he was about 38, he began to have the signs of Huntington's disease, and he went downhill pretty rapidly, so when he was in the early 40s, he died. Well, about the same time, there was another individual who was a psychoanalyst to the stars, Milton Wexler. And he had care of an awful lot of other folk singers out in Hollywood that you know of. And he also happened to have a wife. And the wife he thought was just becoming wacky. And so this resulted actually in a divorce. And then he began to feel very, very guilty when, after the divorce, his wife began to develop the signs and symptoms of Huntington's disease. Well, there were two daughters by this marriage, and they were Nancy Wexler and her sister Alice. And Nancy, and some of you may know her, because she still is very active at Columbia and the Neurologic Institute. Nancy thought that something should be done to locate this gene. Now, Marjorie had an entirely different idea. She felt that money should be raised to take care of these people after they developed their disorder. And what happened was that they decided to join forces. Nancy herself got a PhD in psychology, and she also became sort of psychologist to the stars. So she had a lot of connections with Pete Seeger, Sonny, Cher, Joan Baez, a lot of individuals that were active in this field. And then she decided, well, maybe they ought to get together and have a joint concert. Well, that's when the disagreement broke out about what they should do with the money. And finally, Nancy, who, as I say, is a tiger, she decided that she was going to do it on her own if Marjorie wasn't going to cooperate. So they had this concert. They raised what we would laugh at now is about $250,000, but that seemed a lot more during those years. And so they didn't know what to do with the money. So Nancy went around to various geneticists, and they said, well, why don't we hold a contest? So they did. They held a contest, and a fella who was a PhD student at MIT won, but they had no idea where to go. Somebody came up to Nancy and said, Nancy, around my around a lake, it's really an inlet of the sea, Lake Maracaibo, which is just in the northern part of Venezuela. Around that lake, there must be about 100 people with this disease that have been inbreeding for these many years. Well, she went down with a group of about 6 people from Colombia, and they took blood, and it turned out that there were 2 of them that were mentally retarded from birth, and she did karyotypes on them and found that there was a deletion on the short arm of chromosome 4. So she said to this fellow who was the graduate student, why don't you look at 4? Well, he did. He looked at 4, and he came across what he thought was going to be the gene. And he wanted to see where it was expressed in animals, and it was expressed at the growth plate. So, oh, that doesn't sound at all like this disease. So the first thing he did, he wanted the gene. Turned out to be the gene next to Huntington's. And this, of course, was a condition that was easily recognized. Here, I don't know whether you can see that, but this is a picture by Velázquez, and the people on either side of the princess are the handmaidens, las meninas, and here you can see an achondroplastic dwarf, and this is a hypopituitary dwarf over here, and there's a court dog. And this was quite typical to include individuals who were very short from one condition or another and a court dog in pictures of the 16th and maybe very early 17th century, especially in Habsburg lands. And so what I'm showing you is that the gene to be first discovered was this gene that was unearthed because they were looking for the gene for Huntington's disease. And here you can see the typical phenotype of an individual with achondroplasia. The tush usually sticks out. There's a lordosis, and I think you know that individuals with achondroplasia should not bowl, because your typical stance in bowling is you put your tush out when you throw, and that's not good. And many achondroplasts will develop a spastic tetraplegia as they get older because of reasons I'll show you in a second. Well, here you can see the typical X-ray changes with the slanted metaphyses and other things which I'll diagram for you. Here you can see a quite normal-looking pelvis. Here, these are called pedicles, and we speak of the interpedicular distance as the distance from one pedicle to another pedicle. Now, as one goes down through the lumbar vertebrae, you can see that the interpedicular distance increases. And in the ilium, you can see it's relatively long. And here you can see in the achondroplastic pelvis that there are a number of changes. One, you can see that the interpedicular distance narrows rather than increases, thus further squeezing the nerves. And you can see that the sacrosciatic notch, which is this big thing here, becomes a little structure here. And this tall ilium becomes a relatively short ilium. So the phenotype, the X-ray phenotype, is really quite characteristic. The reason I'm showing you a side view is because we're going to talk about another condition later that involves the face. And you can see that indeed, rather than being rectangular, the vertebral bodies are very square. And here you can normal vertebral body, look at the nice space for the exit of the nerves, and here is a vertebral body from a person with achondroplasia, and this is the little space for the exit of the nerves. So you can see how they can get squished down. The fingers are also fairly characteristic. There is a space because the bones here are wider than normal, so there is that space formed. And now, This used to be terribly rare, but is becoming more common nowadays, because if a person with achondroplasia existed, they usually existed with normal parents in a relatively small town where they would never see, because of the rarity of the condition, another person with achondroplasia. But now you have little people societies for the last 25, 30 years. And there, I don't know whether it's self-selection or what it is, or the frequency, because I think among little people, about 60 to 65% of little people have achondroplasia. So maybe it's just numbers. But it is not uncommon now for a person with achondroplasia to marry another person with achondroplasia. And when that happens, you can get homozygosity of this dominant gene, a double dose of the dominant gene. And that makes for a lethal condition. And this is called homozygous achondroplasia. Now, homozygous achondroplasia can be diagnosed on a molecular basis, and of course that could be the basis for a lot of stories, but this child is newborn and dead, and well, I can't really see this too well from here because of the light, but the vertebral bodies are very, very flat, and here you can see a lot of curvature of the femora. Well, let's see here what we got. Okay, so this is achondroplasia, and as I say, they found this on fibroblast growth factor receptor 3, and they found it right here. That is at the cell surface. Now, each of these fibroblast growth factor receptors are on different chromosomes. This is on chromosome 4, this is on chromosome 10, and this is on chromosome 8. But you see there's only one known condition there, and that we'll talk about in a little bit. But achondroplasia refers to these individuals, and they're located at the cell surface on chromosome 4, the short arm of fibroblast growth factor receptor 3. Okay, now what we're going to do is to sort of group these conditions, because the next condition I want to show you is a relatively mild disorder that blends in with the normal population. And, well, I'm not going to bother you with that. Here is hypochondroplasia. These individuals happen to be a little short, but no big deal. A lot of them are just thought of as short people, and we don't even die. You can see there's no special stigmata associated with facies. I'm going to skip the bone and skip the mutation. But I wanted to show you where the mutation is. It's located in the first kinase of fibroblast growth factor receptor 3. Okay, now, there is a lethal form. See, when I began, and I'm going to talk a little bit more about this later, when I began, there were poor understanding of bone dysplasias. Virtually every little person had some form of achondroplasia. So there was a lethal form of achondroplasia, there was achondroplasia with club, achondroplasia that was classic, there was achondroplasia with unusual ears, etc. And of course all of these are distinct disorders. Now, with regard to regular long bone disorders, there was pile disease, and everything was pile disease. But of course that turned out to be craniometaphyseal and craniodiaphyseal and quite a number of other conditions that we're going to talk about. But this is thanatophoric dysplasia. This is a mutation that is allelic, that is in the same gene. These little triangles. This is known as the interloop area, And here you can see that is also in the interloop area. Here is a different type of thanatophoric dysplasia, and this is in the second kinase. But the difference is pretty striking, and I'll show you this in a second. That's the phenotype. There's a very, very narrow chest here, and you can see that there is no space for breathing, so these kids don't really even take a breath. Now, in the background is the normal situation, and this is achondroplasia in the more black outlined example. You can also see the shape of the vertebral body. Here in thanatophoric dysplasia, they're curved in type 1, and the ilium is even shorter than it is in achondroplasia, and you see the sacrosciatic notch is just literally that, just a notch. So there are many distinct differences. This is this is a dry or zero form of X-ray. You can see these skinny little ribs, and you can see how flat the vertebral bodies are. And these look like French telephones, and here are these crenated ilia. So nobody would have any trouble diagnosing thanatophoric dysplasia. In side view in the zero radiograph, you can again see how almost non-existent these vertebral bodies are. They look more like vertebral plates. And this is a femur, and this is a humerus in these little people. Now, the point is there are two types of thanatophoric dysplasia, one with straight bones and one with curved bones. And let me show you that. Here is a child with straight bones. These individuals have characteristic heads. The heads have Kleeblatt schädel, right? Cloverleaf skull. So this is a very easy condition to diagnose. And here again, this is a zero radiograph. You can see the Kleeblatt schädel here, and you can see the straight femora here. Okay, so much for that. Okay, different mutation, but I'm not going to drive you crazy. Okay, so we've covered all of those. Now the next thing that we're going to look at is fibroblast growth factor receptor 2. And you can see there's a high concentration in the third interglobular loop. And that is the cause. There are many different mutations responsible for Cruzon. Well, okay, that just gives frequency, and I'm not going to bother with that. Okay, here's a Cruzon. And you're all familiar with Cruzon. It has the same frequency, actually, as APERT, 16 per million newborn children has Cruzon. The eyes are very often exophthalmic, and they're separated too far. And this is, along with a number of other conditions, characterized by a craniosynostosis. And there, as you can see, there are lots of mutations. This is only a partial list of the mutations associated with Cruzon. But Cruzon, as I say, is on chromosome 10, and they're all involved with the third interglobular loop. Now, the next condition I wanted to show you is Apert syndrome. Apert syndrome very often has pigment deletion. Now, the reason they have pigment deletion is because there is a P or pigment gene which is located in the same area. And sometimes you get pigment dilution, sometimes you don't. But that's the reason why you do when you do. And here again you can see there's increased distance between the eyes, depressed, and there's a somewhat of a mandibular prognathism. There's a characteristic palate, and they certainly have characteristic alterations in the hands and feet. Here you can see that all the fingers are fused into a mitten-like structure, and the thumb is separate. There is usually a single nail for all of these fused fingers, and the thumb usually has its own nail. And let's see what we got here. Well, in the feet, you have, again, you have a helical nail by itself, and then all the rest of the nails are sort of fused together. And this is the characteristic palate. And you can see that about a third actually have cleft palate, but the 2/3 have what I call a Byzantine arch palate with a sort of minaret-like structure if you were to make a cross section. And there are only 2 mutations associated with Apert syndrome. So now the next condition we want to look at is Pfeiffer. And Pfeiffer syndrome has several different forms, but the most common Pfeiffer is the simple or type 1 Pfeiffer, which is located here on chromosome 8. But there are other Pfeiffers down here, as you can see, and they are of the type 2, the really bad type. Now this woman has typical Pfeiffer. I remember a meeting at which Rudi Pfeiffer came from Germany, and he showed us this new entity, and they have extremities that are different. She was not the smartest lady in the world. This is actually one of our patients, and she had a son, also a little bit not normal, and he was on a Harley, and he went into a bridge abutment right near the university and killed himself. But let me show you what these people look like. Here you can see she has a remarkably flattened face. And here you can see that she has a hand that's characterized by very, very broad thumbs and fingers which are fixed like this. You can't really move the fingers. And let's see what we can, yeah. Okay, the carpal bones are all fused into a conglomerate mass, and here you can see that the terminal phalanx is folded back on itself, thus forming a peculiar terminal phalanx which is extremely wide. Here you see the joint spaces have disappeared, and so that's the reason for the fixation of the digits. The toes are also similarly bizarre. You have a very, very wide hallux, and this is the so-called type 1, and this is the one that's on chromosome 8. Okay, now the next entity I want to talk about is one that is actually the severe form of Pfeiffer. Problems you get in type 1 and sometimes in type 2 is fusion between, let's say, the humerus and one of the forearm bones. It could be with the radius, as it is in this case, but it could also be with the ulna. So you can get lots of combinations of fusion. And that's just mutations in that. All right, now, then this is Jackson-Weiss syndrome. And Jackson-Weiss, Weiss came to one of our meetings, and he talked about this huge kindred in or around Detroit. And these individuals have a face that looks somewhat like Cruzon, but you'll see that they're not. And that does look Cruzon-y. Here you can see that one of the very odd changes is fusion between the metatarsals. Here, the first metatarsal and second metatarsal are fused here, and the same thing over here. So that made it a distinct entity. And these are the mutations in Jackson-Weiss. But let's see where Jackson-Weiss is located. And you see Jackson-Weiss is located right here in fibroblast growth factor receptor 2. Okay, now the next, here let's go back for a second. The next entity was one that I learned about by being at a birth defects meeting, and somebody came up to me and said, I have some slides I'd like to show you. And that's when I made my boo-boo. And they said, oh, we have this black family, and the jaws are really odd looking on x-ray. And I said, oh, well, they're black, and they probably have this cementosis that looks bizarre. But they certainly have strange-looking face. And so we then didn't know what to do with this, but we decided that we'll sort of pursue this. And here you can see these individuals that look cruisinoid, but their neck is on lower face and around the mouth is all deposited with acanthosis nigricans. And here you can see the side view. That looks like Cruzon. Turns out it doesn't even map to chromosome 10. That is one of the mysteries. There are two mysteries that are bugging us right now, and maybe some of you will have some ideas about how to solve the problem, but I'll bring those up in a couple of minutes. This fella certainly was cruisinoid, but look at all this acanthosis nigricans all around him. He had had the correction of the skull for, oh, this is the woman from Jersey City. And I'll show you her daughter, but she has acanthosis nigricans here and around her eyes. And whoops, I don't know who that was, but that might have been her daughter. Yeah, you can see the daughter is similarly affected, and I'll show you the x-rays a little bit later on. This is another individual with acanthosis nigricans and Cruzon. And here, this is what makes this interesting. You remember I mentioned to you that one of the things that it characterizes achondroplasia, as you go down, the interpediculate distance decreases. Well, that's also true here if you were to measure. So I thought that was rather fascinating because you'll see where this gene maps. It maps to the achondroplasia gene on chromosome 4. Now that is bizarre, but there is another condition that maps to the corresponding area on chromosome 10, and that's called SADDAN, S-A-D-D-A-N, and they look like achondroplasts with acanthosis nigricans. So these are the two mysteries I talked about. And here you can see, I also mentioned that you get square vertebral bodies in achondroplasia. And here you have these peculiar vertebral bodies that should be rectangular, but instead they're at least as tall as they are wide. Now, I wanted to show you in an extreme example what the jaws look like. In this syndrome, you have cementomas all over the place, and this makes it really characteristic and unusual. Okay, now even more bizarre, we come to something called Beer-Stevenson syndrome. And here is Beer-Stevenson syndrome. There's a lot of acanthosis nigricans here. This is the umbilical stump, which is very, very wide. There are vertical stripes on the forehead, and they have this brachycephaly. Here you can see the fella better, I hope, than I can. And here you can see in the groin area acanthosis nigricans. I can't even see what that is. Oh, yeah. Yes, this was Beer Stevenson also. I saw this fella down in Sao Paulo, Brazil, and the fella has normal mentation. Here he was, you can see the great big umbilical stump he has here. He has marked contractures in his fingers, and here he has this vertical striping as well as the acanthosis nigricans. He's now in his 20s. And here he is, he doesn't have any choanine. So they had to make choanine for him, just burst through the bone there. And here you can see the contractures in his fingers, and more contractures in his fingers. And the last condition I want to talk about is what we now call fibroblast growth factor receptor 3 synostosis, such that you get facial asymmetry. Now, it's otherwise known as Muenke syndrome after Max Muenke, who came over from Germany and then went with CHOP for a long time, and now he's at NIH. But every once in a while in your craniofacial clinic, you're going to get a history of people who are facially asymmetric. And that's because there is asymmetric fusion of cranial sutures. Maybe a lambdoidal on one side and a coronal on the other. But I thought I'd just show you a little bit about, here is a mother, I think, and here's the baby, and you can see they both have. So the first thing you do is you order fibroblast growth factor receptor 3 analysis, and there are quite a number of labs that'll do that for you. Now, I think that is the end of the first slide box. Now, I thought I'd show you a syndrome that I suspect is new to you, but it is so striking that had it been seen in any part of the world, it would have been recognized as something that you'd never seen before. I had occasion to go down to Bauru, Brazil for quite a number of years to sort of help out down there. And it is an area that is proximate to Minas Gerais, or Gerais. It is the area, you've all been in museums where you've seen these remarkable geodes. Well, that's where they come from. The amethysts and, just beautiful stuff. Well, this is an area that has 40% consanguinity. And so you get all sorts of interesting disorders, because essentially the people stay in this same area and they mate with cousins and they have huge families. Well, I call this entity, I call this Hichieri-Costa syndrome. Richieri-Costa. Hichieri, I know that's the R is pronounced with an H. Hichieri-Costa syndrome. These individuals have somewhat bizarre ears. The eyes are a little bit further apart than normal. And you can see the mandible is very small and the mouth is really small. So let's see where we are. Well, this is not a sibling. I purposely chose individuals from different families to show you the similarity in phenotype. Otherwise, you get this familial thing. Here, the mandible is so small that you have to have some means of breathing. And as I say, the ears are bizarre. Some of the kids have had their ears tacked back in Bauru. But look at this very small mouth. And here's a cleft palate back here. And I wanted to show you that they do not have lower centrals or laterals. They have this groove. The tongue may or may not be attached to the alveolar process, but it is absolutely a 100% feature. And here again, I think the tongue might be attached here. I can't see, but your space is pretty obvious. So this is a cleft syndrome. They do not have a thumb. They have some little appendage sometimes down here, But very striking is the fusion proximally between the fourth and fifth metacarpals. And there are other anomalies in the fingers, but we're not going to deal with that. But the fact that you don't have any thumbs and you have this V-shaped alteration in the metacarpals is really quite striking. And of course, it's recessive. Here is another one with just this little nubbin down here. There are at least 35 cases that I saw down there. So that's quite a collection, and the people were very, very gracious down there. Well, I can't really see. Well, here, I guess I can see this. It looks like the fourth and fifth are fused here. I cannot see because of the light what's over there. Now, even more bizarre are the lower legs, because this is the tibia. And you can see that the end of the tibia is not formed. You can see the fibula is longer than the tibia. You can see there are club feet, etc. So there are lots of stigmata that are easily recognized. You can see that the hallux is foreshortened, and there is club feet in this Hickey-Costa syndrome. Actually, Antonio describes so many syndromes that, you know, what is Hickey-Costa syndrome? There are dozens and dozens of syndromes which include Hickey-Atti's name. Now, what I've done here is I've removed all the normal kids because you'd have a hard time seeing. I think there was 15 in this pedigree, and so you had 4 affected of the 15. So this is just typical recessive, and you can see there's consanguinity here. That's the double line. And okay. Now the next condition I wanted to show you, this being a series of unusual faces. Here you have a condition I first saw when I was doing my first edition with Pinborg in Copenhagen. At that point, a child had been left at an orphan asylum. And she was brought to an institution, and it was soon discovered that she was blind. And she had hair, but the hair all fell out. And she never had teeth. So that was really the first, I didn't know what it was. First time I'd ever seen this syndrome. She was short. And, well, I hope you can see that. That's in side view. I can't even see this, so I don't know what that is.
I think it's
I don't know. No teeth. Okay, no teeth. Okay, yes. No teeth, thank you. We were curious at that time because some of you may remember that one of the theories that was promulgated by Martin Rushton for cleidocranial dysplasia was that the teeth didn't erupt because they had an abnormal cementum. And, you know, it wasn't true, but, you know, that was what he thought. And so Pinborg said, well, he's going to drill a hole in the lower jaw and pull out one of these teeth. So that's why you see a little hole there. I can't really see anything here. Well, there are lots of teeth, and the teeth are just not erupting. Then I had occasion to work for a short period of time as a consultant for the World Health Organization. And while I was there, I began to get slides from all over the world for diagnosis. And this child was a consanguineous child from an uncle-niece union in Israel. I don't know anything further about it. But you can see there's exophthalmos, and there was hair, and the hair all fell out, and there were no teeth. So I coined the name GAPO. G for growth retardation, A for alopecia, P for pseudoanodontia, and O for for optic atrophy, okay, because that's what they have. Not all individuals will have optic atrophy, but a considerable percentage. So then I still didn't know what the genetics was, but the fact that the child was an offspring of a consanguineous union certainly suggested to me we were dealing with something that was recessive. Well, then John Opitz happened to be down in Brazil, and he saw a brother and sister, and they happened to have a superficial fungus infection, so forget that. That's common in the jungle. And this gal did not develop secondary sexual characteristics, and her brother didn't develop secondary sexual characteristics very well. So we began to realize that that was part of the disorder also. Then here's a little child who came from Tennessee, and the parents moved to Little Rock, Arkansas, and as you can see, she has hair. But as she moves to Arkansas, she lost her hair. And so the phenotype began to make more and more sense that we could diagnose this condition. And now, I don't know what we have here. What is that? Face. It's just a face, okay. I think what I'm trying to show is the dilation of the scalp veins up there. And here's another child. Now, I don't remember which one is Turkish and which one is Lebanese, but they both had very, very prominent scalp veins. And I think the next slide should show, yeah, the prominence of the scalp veins here. And that's because the blood is having trouble exiting from the scalp due to the narrowing of vessels. Also, if you look at the fundi, you can see that the vessels are kinkier than they should be. So that was also part of this disorder. But here is this little gal from Arkansas, and you can see lots and lots of teeth. So they have normal teeth. Microscopically, in this Panorex, the teeth, when we took some out, they looked fine. We have no idea why they do not erupt. There's nothing obstructing them, but that is Gapo syndrome. Now, a couple of patients with Gapo syndrome, and I don't remember whether Hetty showed me this or not, but sometimes the tooth buds are pushed together and you get these conglomerate odontomas. So that also is part of the condition. Then, to absolutely confirm the genetic pattern, I forgot to point out to you they all have belly button hernias. Here are three male siblings. And this fellow has his third cranial nerve is knocked out. You can't see the lump on top of his head. This one, you can see the lump on top of his head. These two children were trephined to let out the evil spirits. And they survived, not exactly intact, but they're okay. And here is the family, and you can see there is consanguinity between the parents, and here are the three boys. So that confirmed this autosomal recessive inheritance of Gapo syndrome. Now, the next entity I wanted to show you was one that I coined the name, excuse me, I coined the name ablepharon because they have no eyelids when they're born, and they have macrostomia, big mouth. Now, the way I got involved in this is there's a dysmorphologist geneticist in New York City who lives on Staten Island, and she said, I got a wonderful example of a grandma who believes in malocchio, believes in the evil eye. Ayin hasadin, ayin al-hasid, right? And so, would you like to talk with her? And I said, sure, I'm coming in New York, and anyway, and I'll be happy to come out to Staten Island to see the child. And so here you see a child who has, where is it? Oh, here. Who has no eyelids, but the eyelids have been made for the child, mostly from skin that is redundant on the back of the neck. And then there's macrostomia, and there are colobomata here in the nostril area. So let's take a look at these individuals. Here's another one, and you see this was less successful because the skin at the back of the neck is so thick that it's very hard. Now, here's still another child. If you don't have eyelids and don't protect the eyes, you get this just change in the cornea so that it becomes opacified. You can see the strange nose with the colobomata of the nostrils, and you can also see the large mouth, which has been closed in this child. There's still another child with this. There's a big mouth. And I can't see too well, but that's just another face, I guess. And here's from the side. But what I wanted to show you here is this redundancy of the skin on the back of the neck. Now, they have been making eyelids, as you probably know, from scrotal skin. But it's too pigmented, and so that becomes a problem. And they haven't really solved on a plastic surgical basis exactly what to do for these poor souls. But I'll show you some relatively good results. Here you can see that there's also a prominence of the vasculature of the belly. And the hands have contractures. This shows the redundancy of the skin on the back of the neck. Now, this is the result of, I think this is Ian Jackson's case. Ian saw this child in, of all places, Ireland, and I thought he did remarkably good correction. The ears, they don't have ears, by the way, pinny. They don't have pinny. And so he made sort of ears, and I thought his correction up here was pretty good. He did not correct the colobomata, but he closed the mouth quite well. And here you can see what they don't have are zygomas. So that is also part of the disorder. And so in this child, he made zygomas, and the ears, I think he just gave up and told the kid to just grow hair. And he closed the mouth pretty well. And so ablepharon macrostomia is part of this. Now, they also have genital abnormalities, and this was a male, by the way, and you can see marked genital hypoplasia in these individuals. This was a female, correct? And, well, I don't know what I'm doing here. Okay. Yeah, I guess we can do it this way. Was that anything on the other slide? Can't see it. Okay. Here we have a condition that is dominant. This dominant disorder is characterized by area of aplasia cutis congenita. And here's another child with aplasia cutis congenita. This is bilateral, and it's just more or less anterior to the sternocleidomastoid. The ears are nearly always rotated posteriorly and down. And I that looks to me like a strange-looking ear. And here is the aplasia cutis congenita. And we'll come to this. This is a mother. She also happens to have a white forelock. But the way she corrects her white forelock is to dye everything else white. So now there are lots of ways you can work with this, but you notice that she has a lip which is snarly, for lack of a better term. And it curls upward. And it was actually my observation that I should look at her when I saw her son standing next to her in the dental clinic. And let's see what we see. Okay. Now, here's another lady who has also a white forelock, but she dyed her white forelock to black. And I don't know whether you can see here or not, but she has nasolacrimal obstruction, and she also has these bilateral areas of aplasia cutis congenita. And some of the individuals will have cleft lip, and this fella sort of looks Wardenberg-like, but he isn't. He has the white forelock, and you can see his bizarre lips. And here you can see the scars of aplasia cutis congenita. Now, here is a mother and son, and here you can see the snarly lip in the son. The mother is sort of holding it in. She's much snarlier than that, but I guess when she had her picture taken, she didn't want to look so bad. And I think her hair looks rather attractive. Now, this fellow, you can see, still has the nasolacrimal obstruction up here, and the child also has bilateral cleft lip palate, and also the areas of aplasia cutis congenita on the side of the neck. And here's another fella. His lip is just drawn up in this snarl. He has microphthalmia on one side, and he also has the areas of aplasia cutis congenita. Now, what are we dealing with? Well, you remember from your old histology book that you have your second arch descending, forming the lateral portion of the neck, leaving a small cervical sinus here, which in most cases disappears. And here is your first pharyngeal pouch, which forms your eustachian tube. This forms your tonsil. Here you have, from your third pharyngeal pouch, you have your upper portion, which is the inferior parathyroid and the thymus, and then down here the superior parathyroid and the ultimobranchial body. Well, it turns out that the thymus, rather than descending into the neck, the thymus stays right where it was formed. See, normally you get your descent into the mediastinum of the thymus, but not in this case. Do these individuals have normal thymic function? Do they have normal T cell function? Yes, they do. Does it turn into fat in the side of the neck? Yes, it does. But I wanted to show you microscopically what you're dealing with. Here is the overlying epithelium up here somewhere, and this is a peculiar glandular epithelium, and then this is typical thymus. If you biopsy this stuff on the side of the neck, see, Hassel's corpuscles, see? For your boards. And now the question is, what about this glandular epithelium? Because it turns out to produce mucus. This is just a mucicarmine. And now the question is, what is that epithelium? Well, I think we have pretty well proved what the epithelium is, because the question is it the cervical sinus, which has been maintained, or is it the onlage of the pharyngeal epithelium? Well, the cervical sinus should be lined with stratified squamous, or at least some sort of squamous epithelium, whereas this should be glandular, and this is a cross-section of an embryo. And here you can see that it is a mucus-producing type of epithelium. So this is the onlage epithelium. So this is branchio-oculofacial. Well, let's swap over to the next slide. Carousel, I mean. What we're going to show you now is essentially a continuation of unusual faces. Okay? And here you have a child with Delleman syndrome. Delleman syndrome is characterized by cysts in the brain, that is a poor encephaly, combined with a large number of skin tags and aplasia cutis congenita. Here you can see on the top of the child's skull a number of areas of aplasia cutis congenita, and coming out of the palpebral fissure you have another one of these skin tags, and on the other side it seems to be sort of lateral to the eye slit. Here you can see that there are a number of skin tags in unusual places, but there also happens to be cleft lip. And you can get cleft lip or cleft palate, and we'll talk about the rule of recurrence a little bit later on. Now, this child has a cystic eye as part of the disorder, and I don't think I would have diagnosed it had I not noticed this little area of aplasia cutis congenita above the right auricle. The child subsequently went on to develop a number of skin tags. This is a huge cystic eye, and here you can see the characteristic areas of aplasia cutis congenita above the ear and up into the proximate scalp. It is a non-genetic disorder from what we know. Here you can again see that in this patient there is an area above the pinna, above the helix, and then another area of aplasia cutis congenita behind the ear. Here you can see that some of the individuals will also develop areas of pigmentation. This will be illustrated a little bit later. This child has incredible numbers of these skin tags, and there's been repair, to the best of my knowledge, of the child's lip. You can see also that the ear is posteriorly rotated and low. And here the child also has a facial palsy on one side, as well as the cystic eye and a coloboma of the nostril. And of course the seventh nerve is knocked out, and here you have another area of aplasia cutis congenita. Here, this is a sort of a combination of two disorders that we're going to talk about later, but in differential diagnosis. But here you notice one of them coming out of the nostril, and here's another one on the nasal bridge, as well as the other stigmata that we pointed out. Upside down, but again, areas of aplasia cutis congenita. And here you can see again the colobomata that there are in the eyelids. Here again you have cleft lip, cleft palate, and here you can see the porencephaly, the cysts in the brain. Now, there is a whole form of art created by a people about whom we know not one whit, except that they tattooed the faces of people. And you see this on there, if I can find this. Do you see these little dots? This form of art is called cycladic art, and the individuals who did the cycladic art were sort of southeast of Athens. The largest island in the Cycladic group is Naxos, and that's where the largest repository of Cycladic art was found. This civilization existed before the Mycenaean, and in fact before the Minoan civilization. The art is really very beautiful, and it happens to be one of my favorite forms of art, but we know not a thing about the people. Were they Proto-Greeks? Maybe. It certainly was in that area, but since they left no written records, we don't know anything about them except their art. Naxos, you may remember from maybe your music. There's an opera called Ariadne auf Naxos, and that all comes out of mythology. You remember that Theseus is one of the folk heroes of Greece, and because things at this point in time, let's say 1500 BC, were under the hegemony of Minos, the king of the main island, which is in the southernmost portion off Egypt, but he was the fella who used to have a lot of gold and a lot of wealth in general. And he hired Daedalus, who was a big architect, and his son Icarus. And he told, since he had a bull, a sacred bull, the Minotaur, right? Minos's bull. He had this labyrinth, and he hid the bull in the labyrinth. And there was supposed to be a sacrifice of 12 virgins, male and female, to the bull. And Theseus, in order to prove his worthiness, inserts himself among the group of 12 that were to be sacrificed to the bull of Minos. And no sooner does he arrive than Ariadne, the daughter of Minos, falls in love with him, and she talks to Daedalus and says, how am I going to get my boyfriend out of the labyrinth? So he gives her a ball of twine, and he manages to kill the bull and to get out of the labyrinth. And then he takes her to the island of Naxos, and he abandons her, typical male chauvinist, oink oink. Well, this is the typical art of the Cycladic people. And here you can see, in fact, let's see if we can, what do we focus? Well, just here.
I got it, Bob.
Okay, thank you.
Bob, I think your microphone keeps up.
The microphone is not working? You think it's slipping or what?
No, here's my ear.
Oh, well, okay. Well, you can see Naxos. Here's Naxos right here. And this, of course, is Crete, where all the action took place. Well, that same nose you see in Modigliani's work. And this actually was Jean Hébuterne, who was his mistress. And he had a first child by her, and she was pregnant at the time. And this daughter is now responsible for exhibiting his works around the world. But this is called a Cycladic nose. And this certainly influenced, that is, this form of art influenced a lot of people more than Modigliani. Certainly Picasso, Moore, etc. At any rate, what happened was that he developed a tuberculous meningitis, and she was pregnant about 7 months with his second child, and she took a header out of the second-story window, and that was the end of Jean Hébuterne, but the daughter carries on. And here is actually Modigliani, only he did 15 of works in stone. And I was lucky enough to see this and photograph it, so that he's still into Cycladic noses. Now, let's take a look at Cycladic noses, and you know this as velocardiofacial syndrome. These individuals all pretty much have the same nose, and about 40% of them turn out to be schizophrenic later in life, or at least they have many aspects of schizophrenia. That usually as children, they have a lot of ADD. And they also happen to have what we call allergic shiners as children. This cute little boy was the daughter of the ugliest hooker I have ever seen. She was also affected with the syndrome, and I thought I'd take both her picture and his picture, but I don't know what happened to her picture. This child also has the same nose, and I wanted to show you enough patients with velocardiofacial so that you would have no trouble diagnosing it. Velo because they have velopharyngeal insufficiency. They come in and they talk like this. The soft palate does not approximate the pharynx, and so this is a distinct problem for them. And sometimes people are stupid enough to take out the adenoids, and that only makes it worse, because if they have any degree of normal speech, it's because they have adenoids, because the soft palate will hit the adenoids. So if you do it, well, it's also very dangerous to do a T, that is the tonsillectomy, because you'll see what happens to the carotid. It makes a loop into the fossa, so that's not a good idea. Well, just another guy with it. Still another lady with it. And if there's any fundi that look bizarre, it's their fundi. You see all these kinks all over the place. And there's a big space here between the soft palate and the pharynx. So they have, and I'd say of all the, I don't know what there is about velocardiofacial. But no matter what you do about pharyngeal flaps and lifts and all sorts of things, you never have a normal rate of success. They just don't do very well. Now they have major heart disease, which is the cardio. And many of them have a combination with DeGeorge syndrome. That is, they have a deficiency of T cells and they have parathyroids that aren't there. So I don't know, the back of this came off, and I don't know what to do to this here. No. Well, let's hope it doesn't fall apart. Okay. Well, look, here you can see what happens to the kinks. That goes right into the tonsillar pillar. So if you're pretty frisky in your tonsillectomy, you run into a major bleed, so that's definitely contraindicated. Well, here this was a series of 75 cases, and you can see that 99% have a learning disability. Well, this is not cleft palate, this is cleft insufficiency, or palatal insufficiency, I should say. And it is due to a deletion of 22q11, and of course what you do is a fish, and I'm not going to drive you crazy with fish, but here you can see that there's a marker missing here, and here you have two nice markers. So that's typical thing that you would order for this disorder. Now, I wanted to just review this for a second, and I'm not going to go through the whole thing, but I just want to remind you of these pictures to show you the formation of your face and the formation of the primary palate. Now, this is just a cleft palate, but here are your two palatal processes of the maxilla, and this is your primary palate with the philtral portion and your alveolar portion and your central and lateral incisors. Okay. Now, and, well, we're not going to do that. Okay. Now, I wanted to show you Pi syndrome, P-A-I, because here you have a structure that arises from the columella. Now, here's is even more interesting because here you have a penile structure that's arising from the columella septum, and here's a little structure in here. And usually there's a defect in the middle of the upper lip, and then there is this penile structure occupying the site of the central incisors. In this child, here is this defect in the middle of the upper lip, and here is this peculiar structure. This is all primary palate. And just here you can see the defect in the middle of the upper lip and the nose structure. This penile type structure was removed, and you can see there are two frena, and the frena or frenula are holding down the middle of the upper lip, which is the reason for the defect. Here is in this small black child a small growth here from the septum, as well as that defect in the middle of the upper lip. Here is a different patient with something coming out of the nose here, and the defect in the middle of the upper lip, and this thing. This is all primary palate. And here is this penile type structure, and you'll see when it gets removed, you got two frena. Now, the most interesting thing happened to me. I happened to be flipping through some old journals, and I came across this. And here you can see, this is from a French literature back about 1870. You can see something coming out of the nose, the defect in the middle of the upper lip, running up, and it goes right up to the bregma. And this child died for reasons I do not remember, but nothing to do with these structures. And they noticed that the child did not have a septum pellucidum or corpus callosum, and the child had a lipoma. So I went back and looked at my patients. Sure enough, they don't have a septum pellucidum, and they have a lipoma right anterior to. So I don't know what this means. Ooh, now my batteries are falling out. Story of my life. Yeah, okay. Okay, this should be of no problem to you. It's a characteristic face. Here's this thing. And you have hyperextension of the eye slits. And this is called Kabuki syndrome. Now, admittedly, it was described originally in Japan, and maybe that's why they called it that. You can see that the child must have had a cleft lip, and that has been corrected. The ears are very often large or bizarre or outstanding, and the sclerae are blue. And there is mental retardation and congenital heart disease in Kabuki. Look at the size of the ears, and look at the lateralization of the eye slits. The eyebrows are abnormal in which they are not continuous. And this is Kabuki, because I wanted you to be familiar with Kabuki, and you can see the hyperlateralization of the eye slits. That's real Kabuki. And here you can see this gal with the blue sclerae, and we'll show you some more. This is a non-Japanese child, outstanding ears, and hyperextension of the palpebral fissure. Same thing, blue sclerae, little black child with hyperextension of the eye slits, and premature thelarchy. That's part of the disorder. I'll show you this in other children. They also have at the fingertips what are known as fetal finger pads. And you can see that pretty well. There are other syndromes where you get fetal finger pads, but we're not going to discuss them today. And here's this same young lady who was operated on for her congenital heart anomaly, who has premature thelarchy. Here you can see the hyperextension of the eye slit right here. And they also have a fifth finger which is bent inward, that is clinodactyly. That's also part of the disorder. And here you can see that there is hypoplasia of the middle phalanx of the fifth finger, thus causing the clinodactyly. There are other minor anomalies. Now, another interesting thing is that they do not have the ability to close the eyes when they're sleeping. And this is called lag ophthalmos, like a bunny. Lagos, I don't know why, but I didn't know where bunnies keep their eyes open, but I guess they do. And here in 125 kabukis, you can see that about 90% are retarded, and 100, well, if that's the way we're defining it, I guess 100% have long palpebral fissures, and the eyebrows are arched, but they're also not so good to look at. And 50% have cleft lip or cleft palate, and etc. Well, now, one of the more amazing stories, during the time when there were drug wars in Colombia, and Ochoa was one of the drug kings. A fellow who claimed that Ochoa was not his relative, but was also named Ochoa. His boss, he was a surgeon, a pediatric surgeon that dealt almost exclusively with urogenital problems, but especially kidney problems, kidney ureter bladder problems. And he was living, I think, in Cali. And what happened was that the head of pediatric surgery was killed by the mob. And his life was threatened, and he lived in a very, well, I think it was about a $5 million house. So this was a real problem because he was scared. He had two kids, both of whom happened to be in the States, one in Florida studying immunology and the other in Minnesota studying immunology, getting a PhD. And Papa comes with Mama, and Papa was 58, beautiful to look at. He always used to wear white linen suits. And his English was poor, and he was, as I say, 58, and his chances of getting a job someplace in the States probably wasn't the greatest, and so I'm sure he was a pain in the rear end. And so his son in Florida said, "Why don't you go visit your other son?" So that's how I happened to meet the fella, and we started talking, and he told me a remarkable story, and that's how the syndrome got created. I called it the urofacial syndrome, or Ochoa syndrome, and it's been mapped, but let me tell you about the 45 cases that we unearthed down in Colombia. Well, the way this happened is he got up one morning early. He usually got up, as was his wont, at about 5 o'clock. And on either Wednesday or Thursday, the criada had her day off. So he went down to make himself a cup of coffee. And when he was down there, as skillful as he was in the surgical amphitheater, he was a klutz in the kitchen. And he spilled a cup of coffee on his white linen suit, and he went upstairs to put on another white linen suit. And then he came down, ignored the kitchen, went out to the carport where he kept his Maserati, and he sees he has a flat. And he is convinced that it is the mal de ojo, right? It's the evil eye that's gotten him. So he then goes to take a bus. And on the bus stop, he meets this kid, and the kid smiles at him. Oh, well, he was absolutely convinced. Now, what he's going to do, because his first patient, when he gets to work, he's very disturbed at this point. He gets to work, and his first patient that he's going to work on, he is a very good experimental surgeon, and she has megacystis. She has a huge bladder, and she has huge ureters, and the pelvis of the kidney are all dilated, so sort of a hydronephrosis. So what he's going to do, he's going to take a hunk of gut and sterilize it and attach it to the bladder as a sort of hyperextension of the bladder, and then put in something that he got from Minnesota Mining and Manufacturing, which is a little buzzer. When the bladder gets full, it'll buzz the surface of the skin to say, go pee. So that was his invention. And so that's what he's going to do for this lady. And you'll see her in a second. Now, she's very nervous about this. And so he says, oh, calm down, everything's just fine. And she smiles at him. And he is really... So he says to his assistant, he said, this is what happened to me this morning. She says, I think I know that family. And he says, family? Oh yeah, there's something wrong with their kidneys or bladder. He said, bring them in. So that's the way the whole thing got started. Look at the bladder and the ureters and the calyces. This is major stuff. Now, I wanted to show you some others. Now what they have is paralysis of the lower part of the seventh nerve. And that's all they really have, but it's isolated, and one side has been removed and the other is still dilated. But I wanted to show you that. And these are the patients we found down there. And now, as you probably know, what happened was that Ochoa was killed, and then drugs went under some other big boss down there, and so he returned and apparently is safe. So I don't know what the story is. But why don't we skip this peculiar syndrome and just go on to the next carousel, because I got 10 carousels. And we... Okay, yeah. Here we have a child. We used to have a fella from Thailand who was really quite brilliant. He was a pedodontist, and he took an extra year or two and spent it with me, and we used to call him Nick, because his real name was Piranit Kantaputra, and he was from Chiang Mai. And he's a very sophisticated geneticist. He's also molecular, and I think he makes a living from children's dentistry, but he has discovered so many new diseases in Thailand that he's one of Thailand's big assets. He travels a lot around the world, but he and I were talking over what we were going to see when we went to this hospital. And this actually is a little girl baby who was many operations later. But what we heard through my secretary was that the child had something going in and out in the neck. So you know, there are cases where the heart has been displaced in the neck, but we didn't know what we'd actually see. And when we got there, it turns out that the sternum, the upper portion of the sternum, was missing. This is an artificial sternum. And so you could see the heart go like this, and that's what was going in and out. Now, here we have a line coming up. It's called a raphe, coming up from the belly button. But I wanted to show you what happens in this disorder. But first I wanted to talk about the development of the sternum. It starts off with some mesenchymal condensations. There's actually 3 of them here that condense, and then they form the manubrium of the sternum, and then finally the last thing to unify is the xiphoid. And those individuals with this specific syndrome, and I haven't showed you all the components, will sometimes not even have a sternum. This is known in the literature now as faces, P-H-A-C-E-S. But at the time I gave it a different name, and you can see in this patient the upper portion or manubrium of the sternum is missing. Now, of course, nothing is discovered, you know, it's all been reported before. And I happen to notice back in either the, this is German literature. Here we have from the belly button going north a raphe, and here in this patient you can see there's another raphe here. This is, I think, from the French literature, and here the upper portion of the sternum is gone. Now, the most interesting, however, is what you see in the patient that we saw in this little girl. And here you can see a raphe going up here, and all over the face you see hemangioma. This is not present for the first week of life, but then progresses, and it progresses sometimes quite horribly. Here you can see one in the salivary gland area and on the chin. And I wanted to show you this because I wanted to show you the gal at 8 years of age. Here she is at, I don't know, 1.5 or so, and she still has her hemangioma before the interferon. And here she is later. You can see that she still has some sort of scarred skin, but she had interferon. Some people will use steroids, but I don't think either one is terribly efficacious in treating these individuals. Now, I wanted to show you this because I wanted to show you the progression. This is the first week of life, and here you can see this defect. And this is a little bit later. You can see the superficial hemangioma beginning to develop during the second week of life. This is the 3rd month of life. This is the 4th month of life. And actually, usually these kids do okay. Every once in a while, there'll be some intraoral involvement, but not much. And they very often have abnormal cranial blood supply. And so I describe that association. And here you can see the belly button raphe. Now, at that point, I had seen a number of cases, but I wanted to see if there was a difference, because all the patients I had seen at that point were female. And so I took cases of sternal agenesis and supraumbilical raphe with facial angiomatosis, and you'll notice the ratio is 13:1. So that's the reason I'd seen so many females. But if there was no facial angiomatosis, there was no sex differentiation between the two. Now, I wanted to show you this because I also noted this odd combination, and that is facial angiomatosis with a vermis, cerebellar vermis, that was missing. And that is now all included together in the so-called, here you can see, this is all missing. And this is a little bit of cerebellum. So that is also part of the FACES, P-H-A-C-E-S syndrome. Well, I don't know how he got in there. Well, yeah. Now, this is, what you'll see is that there is a neoplastic or partial neoplastic portion to each of the conditions I'm going to show you over the next 2 boxes. So the hemangioma was one for that. Now, I know you know this condition as one that you don't think is associated with neoplasia, but in fact it is. This is the condition that Bob Goltz and I described way back in the 60s that we call focal dermal hypoplasia. Around the mouth, around the anus, around the vagina, you find these papillomas. And they're really sort of framboisiform. There's usually colobomas in the eye, sometimes one eye, sometimes both eyes. Here you see the ear is simplified, the upper part of the helix is pretty flat, and here you can see the migration of pigment cells, and this was an area of aplasia cutis congenita. And this young lady has had most of her papillomas removed from around her mouth. Her skin still looks fairly bizarre. She has a coloboma at 6 o'clock here, and I think she has a coloboma at 6 o'clock here. And in one of these eyes, there was retinal detachment, as far as I remember. Here you can see where we pick the name focal dermal hypoplasia because the subcutaneous fat, we thought at that time, had herniated up almost underneath the epithelium. And I'll show you an example of that microscopically. Yeah, here you can see the epithelium and then a little bit of connective tissue and then fat. Now at this point, I don't know whether it was subcutaneous fat or whether this is hamartomatous fat. I think I'd suspect the latter. Now they also are missing the right clavicle, and I don't know why that is either. But that is true in a number of disorders. Yeah, here you can see there was only one coloboma here at 6 o'clock. The other one, there was retinal detachment in, but no coloboma. But the teeth are the most bizarre. You can see this is sort of, I guess, a bifid tooth. This is a megatooth. This is sort of a megatooth. This is a microtooth. I'm not even sure it's a tooth. This is a macrotooth, you know, et cetera. These are really bizarre anomalies in focal dermal hypoplasia. Now, what is also seen is abnormalities, almost always unilateral, that is more unilaterally severe because there is bilateral involvement. For example, there's a little syndactyly here. The nails are a little bit hypoplastic, but the middle ray is missing here. And that also occurs in the feet, and I don't remember whether, here's a similar anomaly. I don't remember whether it's the same patient or not. And they also have tails. Now, there are lots of syndromes with tails, but certainly this is one of them. Now, I wanted to show you this, and I don't know whether you can see how striated the bone is, but they have osteopathia striata. And when Mike and I were putting together the latest, no, not the latest edition, the edition before last, I said to Mike, you know, there's something that's not kosher about the bones in this focal dermal hypoplasia. I know about 5 cases of patients that have true giant cell tumor of bone. And here's one involving the upper part of the fibula. Here's one, the lower part of the tibia. I don't know what you call that. And then I'll show you microscope, and here there's a different patient with the lower part of the tibia. Oh, look at that. Cells with, I don't know, 150, maybe more, nuclei. And the amount of stroma they have is not very much. Here's another one, true giant cell tumor of bone. Another one, true giant cell tumor of bone. Another one, etc. Now, here's one for Hetty. Right, Hetty, this is a male. Right?
Well, show me the chromosome.
Right, of course. And Hetty got it right away. What do they have? Klinefelter syndrome is what Hetty's saying. they have an extra X that's saving them. Because this is a condition which is X-linked, dominant, lethal in the male. And the only way the male makes it through is by having Klinefelter syndrome. Okay? That extra X saved the guy. Because if you get a male embryo with the gene, the male embryo is resorbed. Okay? Okay, now, here we have another interesting disorder. And these children are short, and they have a skin that looks like it had been radiated. And that is, they have extensive alteration, a poikiloderma of the skin of the cheeks, and very often of the extremities, and certainly of the tush. Now, this child also has hypoplasia of the radius, which is not uncommon in this specific syndrome. But what they have is osteogenic sarcoma. Here you can see the extremities. Yeah, here's the osteogenic sarcoma. And here's another osteogenic sarcoma. And here in the heel, in the calcaneus, is an osteogenic sarcoma. Here's the osteogenic sarcoma in case you had doubts. Well, let's spend a little time talking about this disorder. I did not bring any of the usual stuff like MEN2B or Poitsiega or anything like that, because you all teach that, and that would be pointless. But this was a kid who was originally diagnosed as having Poitsiega, and the child has much more than that. Let me show you what the child actually has. Here's another one. They look Poitsiega-ish, but they also have blue nevi, and well, you'll see what they all have. This child has blue nevus right here, but they also have lentiginous, as well as freckles, and they also have a characteristic lesion, both males and females, but they're more noted in females, and these are little myxomas, little fibromyxomas, and very often they're located around the areola of the breast. And this is Carney syndrome. It's a dominant disorder. We know where it's located. And here you can see these characteristic myxomas on the eyelids. And unfortunately, sometimes they're removed without any history being taken. Well, here they are. You can see they're myxomas. They don't excite anybody. Now, having areas like this, especially on the genitalia, this is not on the genitalia, would certainly cause me to be counting my beads, but they never, ever do anything, which is interesting. And here you can see, it certainly looks like premelanoma here, but of the caruncle, but nothing happens. And here you can see on the labia, you have your lentigo, but it's not lentigo maligna. Here's another lady with more lentigo. Well, something is, could you sort of kick that up? Yeah, I don't know what that, yeah. Okay. Now, unfortunately, what these children have are myxomas of the heart, and they have multiple myxomas of the heart. Now, I think some of you can go back far enough into your dental and occasionally medical education to realize that when you studied a little bit about oncology, that Alf Knudsen way back talked about retinoblastoma, and he talked about two-hit anti-oncogene stuff. Well, the difference between, say, a genetic tumor and a non-genetic tumor, that is a single gene tumor versus a non-single gene tumor, as in the case of, let's say, pheochromocytoma, in MEN2B, or in say, medullary carcinoma of the thyroid, you have multiple lesions. It's a single gene disorder, okay? So you have multiple primaries, and you have multiple primaries in the heart. And very often people can exist their entire life without parts of the myxoma breaking off, but not uncommonly it does break off. And when it breaks off, it hits little vessels, or occasionally it hits large vessels. And of course, that's a real problem. That's fine. Oh. That's all right. Well, these individuals that have the myxoma, which is very frangible, very friable, breaking off, this stuff floats around the bloodstream, and it'll either give a coronary or a stroke. So that's a real problem. Okay? Well, we'll see. We'll see. Okay, on the dorsum of the tongue, you can see that there are little myxomas, and we'll pray. Prayer doesn't hurt. Okay, well, here you can see just some macrophages gobbling up some of this stuff. This guy, unfortunately, who's missing most of his face, he had along his eyelids a number of these myxomas removed, and somebody removed his maxilla because they thought that this was sarcomatous, and it wasn't. And so it's important to recognize the disorder. Now, they also have these myxofibromas of the breast in this condition. And here you can see a rather large myxofibroma. And in the adrenal gland, you get a replacement of the cortex by this pigmented material. And because of this, the individual will develop a Cushing syndrome. Or sometimes it'll happen in the pituitary, and they will develop either gigantism or acromegaly. And let me show you a guy. Well, here you can see all this pigmented material. This is a bus driver from western Minnesota, and the dermatologist who called me pointed out that he had hundreds, if not thousands, of lentiginous. But his face was getting more and more coarse, and he had these great big hands. And I said, well, bring him in, because he does, I suspect, have acromegaly. And I said, which I think shocked her a little bit, I said, have you felt his testicles? And she said, why would that be? And I said, well, they have Sertoli cell tumors. And so we'll show you one of his testicles. That's his hands. There, he has a Sertoli cell tumor, right? That's what he's got. So that's Carney syndrome. Now, they also have these, they're sort of neural tumors, and there's a lot of fat mixed in, but they have these calcified structures in them that slowly calcify, and they're schwannomas. And you can see that, oh yeah, I forgot to mention, if you get a myxoma of the ear canal, excuse me, and about 15% of these individuals do, myxomas of the ear canal, you can almost put your money on the fact that they have Carney syndrome. Just like if you have a child that you suspect might have early development of Proteus syndrome, and you detect osteomas of the external ear canal, that's another good sign of reinforcement.
I mentioned the myxomas involving the eyelids, the breast, the heart, the oral structures, the ear canals, and the freckles, Gesundheit, Salud, and the blue nevi, and then I mentioned the Cushing's, and then the sexual precocity associated with the Sertoli and the acromegaly, and then the fibromyxoma of the breast and the pseumomatous melanotic schwannomas. So that pretty well does Carney syndrome. Carney was a quite delightful guy. He's still living. Iden was head of surgical path after Dave Darlene retired from Mayo Clinic. Dave died not long ago, as some of you know, but Iden is still holding forth, but he too is retired, and I know he gets a big charge out of people working on the molecular genetics of this disorder. We do know the gene, and there's a fella at NIH who's done most of the work on this genetic disorder. Okay. Yeah, okay. I remember the first time I saw Proteus syndrome. There was a guy that some of you may remember. He was in, I think, the Air Force, but I'm not positive. Joe Fay. He may have been in the Army. Army, okay. And he was stationed at Landstuhl. And one of his hobbies happened to be making fruit wood bowls. And he said, the sergeant in the hobby shop has done me so many favors that I'd like to do him a favor. Would you take a look at the pictures of his kid? And this was his kid. And I didn't know what this was. And you can see that there's various stigmata here that are interesting. His limb length was exaggerated, and the size of his neck was exaggerated. He had normal intelligence. He had a lot of varicose veins from the knee on down. He couldn't stand upright because one leg was longer than the other, and the fingers certainly were disproportionate, and his trunk was disproportionate, and there were other stigmata that we can point out in other patients. Now, very shortly thereafter, I told Joe I didn't know what this was. A gal who has left the field at Ohio State, a gal named Stella Contrast. Stella, I understand, went into psychiatry. But she sent me pictures of this patient, and I said, well, I don't know what it is, but a guy named Joe Fay at Landstuhl has another patient. And why don't you get together with Joe and write this up? And they never did. And that was, I guess, all I knew about this patient at that time. Then I happened to be in Dublin. And I was talking about some deafness syndromes, which is my other interest. And one of the people sitting in the front row said, would you mind coming to a grocery store with me after the lecture? And I said, well, sure. And the people that own the store have a child. And I looked at the child. Sure enough, the child had the same condition. So we took the child in the back room, and we photographed the child. And then took the child to the hospital and did some more pictures. But I wanted to show you what these people look like. You see there's a relaxation of the abdominal musculature, among other things. The head is larger than normal, and there's a redundancy of the connective tissue. You can see the connective tissue from the palm actually coming over on the side of the hand, and you can see what looks a little bit cerebriform or gyrate on the dorsum, but nothing compared to the palmar aspect of the hands. And you can see that the bone is chaotic in its formation. Here you see that they look upside down. I suppose there's an epiphysis up here. that's the opposite of the normal way. So you get a lot of anomalies of bones in Proteus syndrome. There are also a lot of other tumors that are formed. There's a lipoma here, there's an epithelial nevus, here's an epithelial nevus. So there are lots of anomalies in Proteus syndrome. Here is an individual who has a hunk of cotton in the ear because there was an osteoma. And here was a tumor, monomorphic adenoma of the parotid that turns out to be part of the disorder. Monomorphic tumor of the parotid. There are other tumors we'll talk about. Here you can see a little redundancy of the mucosa, and we'll look at her in a little bit different way. Here you can see a crest of bone up here, so that there's lots of asymmetry in this disorder. There was a hamartoma here on the dorsum of the tongue. There was a hamartoma of the tonsillar area. Here you can see in a different patient the osteoma of the ear canal. And here you can see the epithelial nevus on the neck of one of these individuals. And it, looks like acanthosis nigricans, but it's really an epithelial nevus by history. And here you see several interesting things. Here's a hamartoma. And here you can see there's some sort of hamartoma here of the alveolar bone. And, and the teeth are canted. And here you can see this epibulbar dermoid, but it's usually not in the position that you see in OAV. But most characteristic are what we call moccasin lesions. And the same thing that I showed you on the palm, you see on the sole of the foot. And let me show you. This is this little Irish child, and you can see one foot here is pretty large with a lot of this stuff. And the other foot looks pretty good, except for an area down here. This happens not at birth, but sometimes there are children born with it. It usually develops, which is why they call it Proteus syndrome. The good god Proteus had the ability to change his shape at will in order to escape detection. And some of you may remember back in the Odyssey where, who was it, Odysseus' son, was it Laertes, I think, was worried about all these suitors trying to get the rich widow, his mother. So he goes down, he talks to the smart person in the group, Mentor, which is where our word comes from. And Mentor said, well, you go out on this island and you get dressed up in seal skins and you lie there on the beach, and pretty soon Proteus, who is the son of Poseidon, will probably lie down there, but he in an instant can transform himself into fire or anything. So that's why they call it Proteus syndrome, because these individuals by and large are formed normally and they keep changing with time. Okay, well, that's on the chest. Well, this is another lesion that is relatively common, and that is they have these ovarian cysts, which may be serous or may be mucus. And in that case, it was mucus. And so Mike and I pulled together a number of things to see just what looked pretty good. And 3 of them had meningiomas. At the time, we were looking at about 20 cases. And at that time, 2 of them had monomorphic adenoma of the parotid. And this ovarian thing probably meant something. And these odd testicular tumors were so odd that they surely have significance. Now, Mike has been keeping a running tab on all the strange tumors, and I don't know how many patients he has now tabulated. But it again emphasized that testicular and ovarian and salivary and meningeal are the odd things about the neoplasms in this disorder. And then Mike got so pissed off that he didn't get credit for originally describing the entity, because in fact he did. His mistake, and there must be a lesson there for all of us, was to put it in journals that nobody reads. And that Mike had 2 patients, and he put them in some little journal, and then he wrote a book called A Child with Multiple Malformations, and it's clearly antedated the report out of Germany, but the fellow who described it in Germany was very interested in myths. And the idea of naming disorder after a character from a myth appealed to the general medical public. So that's how it got its name. So Mike then said, well, you know, I think that Merrick, the elephant man, probably had the disease. So he flew to London to look at the disease. You know, that hype about our friend buying Merrick's skeleton was just that. It was just hype. No real chance. But here you can see Merrick, and that's a cast of Merrick's sole of his foot. And of course, we came up with the notion that this was a P10 alteration, and 25% of patients with Proteus syndrome have the P10 mutation on chromosome 10, and 75% of patients with Proteus-like syndrome have P10 mutations. So that, I thought, that was published in Lancet a while back. And of course, you see P10 mutations in lots of different things, among them Cowden syndrome and Banyan-Riley-Ruvalcaba. Now, here this is Cowden's, and let me tell you a little bit about Cowden's. I was down at the AFIP, and I think I was giving a talk there, and Southern Hooker said to me, would you take a look at a tray of slides? And I looked, and this is the lady during life. She had breasts that were larger than normal, but she also had benign tumors and malignant tumors of the breasts, and she had a thyroid tumor. I don't remember whether it was benign or malignant. And she had a lot of little papillomas and funny things on her gums and funny things on her lips. And I didn't know what it was, and I just handed him the tray back after a half an hour, and I said, I've never seen it before. So about 6 months later, Lauren Ackerman contacted me, and he said, Bob, I got a gal with this, and this. And I said, wow. I don't know the name for it, but I said, there's another one at the AFIP. And he said, would you find out who sent it in? And I said, well, if I can, I remember the name of the guy who sent it, who showed it to me, Southern Hooker. And Southern was, as far as I know, a direct lineal descendant of the Southern Hooker from Civil War fame. That's where the word hooker comes from. Camp followers and all that. That's supposedly true. Well, at any rate, let me show you a little bit about this, because Lauren's patient is here, and she also had very large breasts, and she had many of the same stigmata that Southern's patient had. And here you can see all these tricholamomas scattered over the face, and here over the lips. But you can have relatively mild ones, or not so mild ones, or really not so mild ones, or bad ones. And these are really Frambeziform types of papillomas that you can get in Cowden syndrome. Now, this is a patient that I think was either seen in Brazil or someplace in South America. I don't remember. But you can see that she has the fairly typical stigmata of the disorder. And this is just a higher power. of her mouth. Now, this was a strange story. I went out to the VA, and I think I used to give them a little talk, half-hour talk. And they said, well, would you look at this patient who has denture injury tumors but no denture? And I said, well, take a look at the tongue, because he's got an awful lot of stuff in the tongue. And I said, do you know why he's here? Well, he was there actually because he had intestinal CA, which is not supposed to be part of the disorder, but that's what he had. And here you can take a look at the tongue of a patient with, microscopically, if you were to just clip one of these things off and send it in to an oral pathologist or general pathologist, they'd say, oh, hyperplasia or fibroepithelial lesion or something. You need to tell them the whole story, otherwise they're not going to make the diagnosis. Well, something didn't do something. Okay. All right. Okay. Well, here you can see there's stuff on the inside. Okay. Now, and then there's also stuff on the outside, which I guess didn't drop. Now, another interesting aspect is this linear keratosis that starts on the thumb and comes down. Not all patients will have this, but enough do. And here you can see these tricholamomas that are interesting and rather beautiful tumors. And here you can see a tricholamoma, and it has a palisaded area, which I'll show you in a second. Yeah, see, there's very nice palisaded cells. Yeah, now, okay, here we have an enlargement of the thyroid. And this gal, let's see, I don't know whether we can go back or not. No, okay. Yeah, no, that's right. Yeah, she had a thyroid thing, and that was a Hürthle cell. Whoop, sorry. She had Cowden's and then a Hürthle cell. Yeah, could you go back one? Yeah, that was a Hürthle cell. Okay, that's fine. Okay, well, you see that malignant neoplasms of the gut are pretty rare, so maybe this was just chance. I don't know, really. Okay, now this is still another entity, Banyan zonana, or whatever you want to call this, Ruvalcaba Myrie-Smith. Here you see some lipomas. But this is also a P10 mutation. So they're allelic mutations. Here you can see an elbow with a lipoma. And here you can see the gut with all sorts of polyps. And these polyps are very often juvenile polyps, and they're covered by a lot of mucus and serum. And so the person will develop a very low protein as a result of losing all the protein through the gut. Sometimes the polyps will present through the anal orifice, and sometimes they'll present because of hemorrhage. Now, one of the stranger experiences I had with this is there was a guy who was about 6'7", and I used to see him on the elevator, and he was bald because he had this autoimmune loss of hair. And we often smiled at each other and chatted. And he said, could I ask you a personal question? I said, sure. He said, I got lipomas, and I got this, and I got that. And he said, is that an entity? He says, I also have a speckled penis. So I was hoping he wouldn't pull it out in the... But he said, this runs in the family too. So I said, well, I see your head is larger. Oh, yeah, he said, I have a 62 centimeter head. So I said, okay. And I said, yeah, I don't mind. So he comes in. Sure enough, his penis was speckled. This is his nephew's penis. And so that's part of this disorder. And we also noticed that most of the people in his family had an enlarged thyroid, but it was euthyroid. It wasn't overactive or underactive. So we did a biopsy, and we found he had Hashimoto's thyroiditis, autoimmune thyroiditis. Now, I thought maybe the baldness had, the autoimmune baldness had something to do with it, and maybe it does, but no other patients have been described with it. So I don't know what that means. Yeah, here you can see how speckled some of these penises can be. Now, they also, and this was true with a number of my patients, they developed very painful testicles. And what they have is infiltration with fat. And I don't understand the mechanism, but they do have painful testicles. Sometimes I have to get them removed. And here you can see the autoimmune thyroiditis, the Hashimoto's. Well, this is just my syndrome, the nevoid basal cell. Of course, a lot of people described it before I did, but for some crazy reason, they gave me the credit for it. And here you can see a fellow with a head that's too big. I'm not going to drive you crazy with all this stuff. Here are, 10,000 basal cell carcinomas involving the neck. And some are pigmented, some are not pigmented. Here you can see a basal cell carcinoma with a little bit of calcium, and I'll tell you in the end what I think that's due to. But here you can see two things. You can see your basal cell carcinoma. Here's a little bit of calcium. And this is a little milium. It's just a little cyst of no consequence. And these individuals will have holes in the palm sometimes. Holes in, and here you can see, this is obviously palmar or plantar. This is the stratum corneum. And then down at the bottom, where you sometimes see basal cell carcinomas develop, you'll get a dishesion among the cells. And here you can see the calcification of the falx. And here you can see the calcification of the falx and the tentorium cerebelli and the fusion between the anterior and posterior clinoids. And this perhaps is the most striking bifid rib example. I happen to be going through a private museum in Amsterdam. It's in the basement of the major health science center. And there were a whole family of these, and I'm pretty sure that's what they got. But it dates from 1870, so there's no history. But that at least is a reasonable thought. Well, there's just more stuff. And about 10 to 15% will have cysts of the extremities. And 40%, believe it or not, at some time in their lives, will have transient epithelial cysts of the eyelids. And I'm getting the patient to evert the eyelids, and so I can photograph them. But mostly they have one isolated one or two isolated ones. But this looks much more dramatic. And I remember when I first saw this, that is, a lot of these gals have owies, and when you x-ray them, you realize they're bilateral calcified masses, occasionally unilateral, but remember this is a genetic disorder, so to have multiple ovarian fibromas is more common, and sometimes there's a little heterotopic calcification. But they're weighty, and they twist on their pedicles, and so it makes owies, and it's not a pleasant thing to have. The cysts and the cardiac fibromas. They're usually multi-sited, multifocal, and here This gal has had the medulloblastoma removed, and she has thousands of basal cell carcinomas. And this is just a little biopsy site. And here's a medulloblastoma. They are all desmoplastic, every one of them. I reviewed about 75 of them. Every one of them was desmoplastic type of medulloblastoma. And flame lucencies, I don't know, about 40% will have these flame lucencies. And the only time they become of interest is when they involve the calvarium. And if they happen to have had a history of medulloblastoma, you worry about the spread. And here is a guy who had medulloblastoma and the syndrome. And of course, he got radiated down the spine and the base of the skull and developed tens of thousands of basal cell carcinomas 7 or 8 years post-radiation. Well, we're not going to do that. We're not going to do that. Well, this is the point at which we wondered whether we could diagnose what this kid had. And we use flanking markers, and you can see that this affected individual, the flanking markers mapped out 1-3. This is an unaffected person, 3-2, another unaffected person, 2-1, another unaffected person, 2-1, and this affected person again, 1-3. This is a 1-3, this is a 1-3, and the unaffected baby, the unborn baby was a 1-3, so we predicted that the child would be affected, and the child was. So that was the use of markers. Now, it's rather interesting that since this slide was made, we know a lot more about signaling, and I've been very fortunate to have been selected to give the Nobel lecture with Max Muncke in Stockholm in August. And so I'm going to talk about, there's a 3-day conference on hedgehog. The first is hedgehog and the fruit fly, hedgehog and the mouse, and the third day, hedgehog and people. And I'm going to talk about nevoid basal cell and the signaling mechanism. And Max is going to talk about holoprosencephaly and the hedgehog mechanism. But a few months back, we thought that patched, which is my gene, which is mutated, and is the receptor for sonic hedgehog, is attached to a cholesterol moiety. And but we now know that on this side there's a palmitate moiety. And the purpose of patched is to suppress smoothened, which is next to it. Smoothened's role is to send signal transductions through pKa and costal 2 infused, etc., and then to the glies, which act as transcription factors, and then down to the nucleus. And the nucleus ultimately puts out more patch, puts out Wnt, or wingless, and decapentaplegic, which is bone morphogenetic protein. Now, to get back to the general concept of what I think this little calcium, which is deposited in nearly all the basal cell carcinomas, I think it's a reflection of bone morphogenetic protein, which is also produced. Now, the role of patched is to say to the basal cells, go forth and multiply, go forth and multiply, go forth and multiply. And that's precisely what they do. And it doesn't make any difference whether you're talking about one little old basal cell carcinoma or 10,000 basal cell carcinomas. In the case where you have only an isolated basal cell carcinoma, you have to have the 2 mutations in the same nucleus. In the case of the syndrome, every cell in your body already has 1 mutation, so you only need 1 more. That's typical Knudsen 2-hit hypothesis. What's come into interest recently has been cathepsin chemistry. And we're going to talk a little bit about cathepsins, these peculiar proteases, and of course the disorder that you've had the greatest interest in with regard to cathepsins probably is Papillon-Lefebvre, right? In which you're dealing with cathepsin C. Well, a number of the cathepsins, we don't really know what their function is, but we know that they are proteases. And the latest one of interest happens to be pycnodysostoses. That's cathepsin K, and there's all sorts of fascinating stories related to pycnodysostoses. The name pycno refers to small, as in picnic, P-Y-C-N-I-C. And you have a person here who is really quite short, and yet they're reasonably proportionate. And I think you'll probably recognize a phenotype from an old Greek piece of pottery that does look remarkably like Toulouse-Lautrec. Here's Toulouse-Lautrec. Now, it's rather interesting that when Lamy and Maritou described pycnodysostoses back in maybe 1962, I think I'm going to lean on the chair here, but the back is killing me. Well, maybe I'll sit, yeah. Lamy was head of pediatrics at Necker in Paris, and Maritou is living. He's even older than I am. Radiologist, and really was one of the world's prime radiologists. Thank you, aren't you nice? Yeah. I'll put this here. Well, they were so convinced that Toulouse-Lautrec had pycnodysostoses that they actually headed off in their little Renault and they went down to the town of Albi, which was the site of the Albigensian heresy that some of you may know about. It's right near Toulouse, and it antedated this heresy antedated the Crusades. So you could call it maybe the pre-First Crusade. And these people were Manichaean, really, in philosophy. They had a god of light, a god of darkness, a god of good, a god of evil, a sort of Ahura Mazda and Ahriman. Mazda gives, I don't know whether any of you remember Mazda light bulbs, but that was the god of light in the Persian hierarchy of gods. And so they found, of course, that Toulouse-Lautrec didn't have any kids, at least that we're aware of, but he did have a brother, and the brother had kids, and so they finally found some relatives. And the relatives said, no, you cannot dig his body up to prove your little theory. So this was in 1962, I'd say. And then everybody sort of forgot the issue until Bobby Desnick in New York, attached to Mount Sinai, and Bruce Gelb, his associate, decided that they were, because they knew where the gene mapped to, near the bottom of chromosome 1, that they were going to look at cathepsin K. And indeed, that's what they did. And so they figured, well, this is a very nifty way to diagnose what Toulouse-Lautrec has. Meanwhile, Lamy had died, and so they got Maritou, who was well up into his 80s, and they said, how about coming down with us and being our negotiator? And they found the same family down there, and they said, yeah, we'll sell you our blood for $2,000 a tube. So that was the end of that. So that's pretty much where we were. And this is a La Goulou, one of his and my favorite portraits. This is not published, by the way. It's from a family collection, and that's another one of his pictures of himself. This is also from a family collection of him nude in a rowboat. Well, the phenotype is pretty characteristic. There's increased density of the bone, and you figure, well, maybe this is a disease of osteoclasts. Well, in a sense, it is. But the osteoclasts are normal in number and in phenotype, and they got that nice ruffled border. But what they have is they got vacuoles in the cytoplasm, and this is where they're not able to die. You have a lot of free-floating collagen fibers in those vesicles in there. So this is a cathepsin disease. Now let me show you what you have. You have a skull in which your fontanelles remain open, and you also have no angle to the mandible, and I don't exactly understand the dynamics, but it's not rare to get a fracture here. And then you get this hyperplastic callus in association with this. We just had a gal that I diagnosed when she was a baby in Minneapolis. And she's now in her 30s, I guess, and she just fractured her jaw. You notice there's an increased density to the bone, and here you can see there is no angle to the mandible. It goes straight down from the condyle to the menton, and you can see the wide open sutures and fontanelles and what have you in this disorder. And there is a sort of tendency toward a round face, and certainly very short stature, and you can see in this adult that the sutures are still open. And here's another person, and this is where they'll get the fracture. Wide open, wide open. And here you can see, again, it goes from the condyle down to the menton. Same sort of thing. Now, the fingers are, on X-ray, sort of interesting. And you notice that the terminal phalanges are not formed except usually on the fourth finger. That one's usually okay. But the bone has increased density. And here you can see there was a fracture here and a fracture here. They don't get as many fractures as you might imagine, but certainly that jaw fracture at that site, I suppose it's a matter of, I mean, if I were a mechanic, knew all about things like that, I could understand why it would fracture here, but I don't. And maybe some of you who have engineering backgrounds could figure out why they get those jaw fractures. Short stature and dense bones and short terminal phalanges, et cetera, et cetera. I say it maps to the long arm of the chromosome number 1, and it's a mutation in cathepsin K. And I mentioned already that the number of osteoclasts is normal, and they got those nice ruffled flicky-dickies, but they got these vacuoles that are filled with collagen fibrils, so that the osteoclasts demineralize, but they do not have because of the cathepsin K deficiency. Now, I don't know whether any of you know this variant of Papillon-Lefebvre. Do you all know the variant? It's called Chaim-Monk, and I'll show you Chaim-Monk. Well, this is what cathepsins do, and you see they have a lot of cathepsins that differ in pH stability and substrate specificities, but by and large they're involved in a lot of destructions. Well, it really doesn't say anything I didn't already say. This is Chaim-Monk. Now, Chaim-Monk is it's allelic with Papillon-Lefebvre. It's cathepsin C. The fingers are hyperextended, and the terminal phalanges have these volar curves, and it makes the fingers look like claws. The group that has this now live entirely in Israel, as far as I know, but they came from India, in Cochin, India, and so they're Cochin Indian Jews. And, well, you can see that's what they look like. Look at the claws. And I thought that's sufficiently interesting to show you. Now, Hetty and I don't know whether Hetty even remembers this, but yeah, Hetty and I were working on Picno 2,000 years ago. And I remember Hetty coming up to me and saying, you know, this old patient reported by, who was it, Cavalazzi? Back in 1923 in southern Italy, that is not Picno. And I said, yeah, I agree with you. That's not Picno. What the hell is it? And so the x-rays were pretty bad, and it wasn't for a while till we figured out what this little kid has, because you see the kid doesn't have clavicles. Well, here is an interesting disorder. They have a different type of jaw. It just comes down. And they have also wide open fontanelles. And here they are, mandibulo-acral dysplasia. And I'll show you mandibulo-acral dysplasia. And I'll tell you a little bit about the molecular genetics, because we have a whole new field of laminopathies, in other words, of laminin AC or lamin AC. And this is really so brand new that in the last few issues of Nature Genetics and Journal of Medical Genetics, the British journal, we have articles on lamin A and the multitude of disorders associated with lamin A pathology. And then we'll get to filamin A, which is my baby, and I'll talk to you about that. Well, let's take a look at these people. They don't have a tush, among other things. That makes it interesting. They don't have clavicles that amount to anything. They have this thing that almost looks like Treacher Collins, that down sweep. And little hunks of calcium come out of the fingers. See, they don't have clavicles. Here's another one. And they don't have much in the way of mandibles either. See, look at all those little islands in here. It stays open. See, look at how it stayed open. And they don't have a tush. And look at the hands. Again, very similar to each other. And the thumb is wider than it should be, and the terminal phalanges are narrower than they should be. Well, here the terminal phalanges have largely disappeared, but, well, we come to the discussion of the lamins. There are three genes, lamin A. We don't know much about lamin B1 or B2, but these lamins are underneath, well, wherever you have a lamina. And here, in muscle, you have laminas. In epithelial tissues, you have laminas. In kidney glomeruli, you have laminas. And this is what lamin looks like. Here you have your central branch, and then you have your bees coiled around it. Okay? So that's what lamin gene looks like. Now take a look at this remarkable collection of things that are laminopathies. Progeria You know, where you look like you're 100 years old when you're 14 and you die of coronaries and strokes? Well, that is a laminopathy, mandibuloacral. This Dunnigan-type lipodystrophy, where all the fat disappears from the top of your body and lands in your tush, that is one of the Emery-Dreifuss muscular dystrophy, one of the Charcot-Marie tooth diseases. And this specific entity that we just talked about, it's a recessive, like pycnodysostoses is a recessive. You remember that Toulouse-Lautrec's folks were first cousins. Now, did he fracture? Yeah, he fractured. He fell from a horse, but I think it was appropriate. And they're normal at birth, and then they lose this fat. And why they lose it on their tush, I don't know. But it is characteristic, and they have this exophthalmos, and they got this odd beak nose. And, well, I just wrote some of the anomalies that are present. They have no cellular cementum. I don't know, that was just a chance discovery, because they had some people that had some teeth taken out in Minnesota. So we made that observation. And some of them will have acanthosis nigricans, again, because there is an insulin binding defect. Now, one of the other conditions I'd like to show you is Hydu-Cheney disease, which has been called acroosteolysis as well. And these individuals really have a strange face and strange teeth and strange hands. They don't look too happy. I guess they got a lot of hair. And many of them really are hirsute. And you can see they have very wide thumbs. The terminal phalanges are short. And they have a head. They have platybasia, and they have a head that looks like a mushroom on a stick. And they also have, well, you can see how long the head is, and very often there are neurologic problems because of the platybasia. And you actually have the first arch inside the skull. So you get compression, you get a lot of these little islands. See, they all have this round face except for that guy. And this is the odd jaw formation they have. Well, maybe. What? Okay. Okay, well, they keep losing these teeth. Uh-oh.
Got it.
Okay. Yeah, here you can see the short terminal phalanges. Now, look at the fourth finger. That looks normal, but the rest of them are abbreviated. All right, I think we have, what the pictures are going to show is that all the terminal phalanges, well, that's just another guy. Okay, sorry about that.
Oh no! Houston, we have a problem.
Yeah, it's all right, you're doing fine.
Yeah, I got it.
Okay. Yeah. Yeah, okay. Now, this was an exception because this fourth finger looks pretty good. But you can see why they call this acroosteolysis. Okay? Yeah, see, here's another one. Oh, I'm sorry. I'll tell you what this is. There is a firm, a company in Minneapolis that takes a substance and makes a polymer out of it. And I don't remember what the polymer is, but the janitors go in and they clean out this large bowl. And if they get their fingers exposed to this monomer that hasn't been converted, it causes dissolution of the terminal phalanges. So it is, just a mimicking thing. Okay, well, you can see they also have an osteoporosis. Very often they have knock knees. And here you can see again this long head with all these extra little islands. There isn't very much bone in here. And this is what the teeth look like in Hydu-Cheney syndrome. Okay, dissolution of the terminal phalanges, platybasia, bizarrely shaped skull, premature loss of teeth, short stature, and it's a dominant. And the head does appear large, and there's plenty of scalp hair, and it is quite low, and they often have fusion of the eyebrows in the middle that is synophorous, and this long philtrum that you saw. Sensory neural hearing loss and conductive hearing loss are common, and a number of them will have renal cortical cysts. Hairiness, wide nails, impaction of the cerebellum into the foramen magnum that I told you causes a lot of neurologic problems, and this bathrocephaly, which is the mushroom on a stick. And here again, just the fingers of one of these patients. And these are some other pictures of this substance that is polymerized. And that's it in that jar. Okay? We got another jar coming up. Okay. As I said before, when I got in this field, things were, long tubular bone disorders were called pile disease. And it was because a fella from Germany named Jürgen Spranger was visiting Lenny Langer, who is now deep into Alzheimer's in town. He was one of the greatest of bone X-ray people. And he wasn't a great communicator, but he sure was smart. And Lenny was going to write a book, and in fact did write a book, Langer, Spranger, and Wiedemann. Wiedemann was, in a different context. Wiedemann was maybe the first person to observe the thalidomide, thalidomida contergan is what the Germans called it. And the one that made the actual observation and said, it is contergan that's doing this, is Widukind Lenz. And Lenz died a while back, but Lenz's papa was one of the infamous three that were into the Endlösung, the final solution. Mengele was one of them, Widukind Lenz's papa, Fritz František Lenz, and Verschurer was the third one. And I remember reading a little monograph in German about interviews with the children of the Nazi doctors, and they were all into denial. You can imagine that. I remember they interviewed Widukind, whom I knew really well, and they said, well, what was Dr. Verschurer like? Oh, he was very religious. I'm sure he was. But Widukind, after he made this discovery that it was due to contergan, he was sued by the company that was Grünenthaler Chemie. And they brought in some Nobel Prize winners from Germany saying that his work was worthless, but he stuck to it and he proved it. And then they called in some goons and they firebombed his house. And his son, who was always a little bit flaky, committed suicide on Kristallnacht. So I don't know, whether that was coincidental or not. But it was a very strange thing. But when Jürgen Spranger came over, I really did have a couple of brothers with true pile disease, and we were talking about what a mess the literature is, and maybe when he wasn't working with Lenny, maybe we could write something on craniotubular bone dysplasias. So we did in the 60s, and the first condition that we identified was craniometaphyseal dysplasia. And we recognized first that there was a dominant form and a recessive form. And then we made an error, and we said, oh, the recessive form can be separated from the dominant form because it's more severe. It turns out that the individual case is the determining factor. Now, here you can see this paranasal bone in both the mother and the son in this dominant form. And this happens to be a recessive, and it's bad, but that was what we illustrated the thing with. And this is the guy's sister. I think they came from Puerto Rico. And here you can see a little kid. This happens to be the dominant form. And here you can see all of this paranasal bone, which is deposited. This is part of a large family, and this fellow is now in his 40s, and he is totally deaf, which is in part the reason he's been banned from the dental school. He hits people, because if he doesn't understand, that's his way. He lashes out and just hits people. He did not understand that when you take an impression, see, this is a progressive disease. He didn't understand that when you take an impression, that impression is destroyed when you make casts. And so his partial denture didn't fit him anymore, so he took some pliers and he pulled it out and then wanted it put back on the original cast, and of course that was long destroyed. And so here he is with a little facial palsy, but here he is, maybe he was 18, I guess, something like that. And here he is a little bit older. Now at this point, a lot of material had been removed, but in the process of removing it, he started bleeding, and they finally had to fix him with bone wax after 7 hours of attempt to stop his bleeding. And finally, he was operated on at Mayo Clinic, and he still doesn't look good, and the disease is progressive, and he is essentially a hermit. And he has lost any hearing that he ever had. This is his sister. She's now out in Vegas, and here she looks pretty good. Doesn't have too much paranasal bone at this stage of the game, but she also is totally paralyzed now on the one side. And she has a son whose picture, this is when he was about 7 or 8, I guess. And he came in to see me recently with a girlfriend, and I explained to the girlfriend a little bit about the genetics and the 50% chance that they would transmit it and how we could diagnose it before birth, and I don't know. It was a question of whether that was more than they wanted to know. You can see that the bones in general are dense, but they're not fully architectized. And here you can see the humerus is shorter than it should be, and both the forearm bones are not fully architectized. And here, these look somewhat like an Erlenmeyer flask, and that's what they speak of this as, an Erlenmeyer flask alteration. Not the same as that which you get in the true metaphyseal dysplasia, or metaphyseal dysplasia, which is Pile's disease. There it's an entirely different type of alteration, but you notice that there's increased density in the diaphyses. Here, look how dense the diaphyses are and how poorly dense the metaphyses are. Let's skip that. And the ribs are widened in craniometaphyseal. And you see that the two genes, the dominant and the recessive form, map to different sites. Now, this is another thing I got into. I found the gene. It's called the ANK gene, A-N-K or A-N-K-H. And they call it that because you get an ankylosis in mice that are homozygous for the mutation. And what this gene is, it's involved in pyrophosphate metabolism. And the pyrophosphate comes from the cell into the extracellular matrix, and it's with the blessing of the ANK gene. Now, if that gets mutated, you get a failure of transportation of your pyrophosphate. See, since reduced pyrophosphate increases mineralization. So that's your story on. Now let me show you the gene. It's one of these multi-pass genes in the cell surface. So here's your cell surface. And all the mutations occur here in the 1, 2, 3, 4 intracellular loop. All of them occur at this site. And yeah, this is the paper which we talk about the dominant form. Now, here is a remarkable syndrome, and in the next to the last issue of Nature Genetics, I reported what the gene is and where it's located, and that it is allelic to X-linked microphthalmia, or lens, same lens, microphthalmia. Now, I remember, and it might have been when Hedy was there, that a very nice guy named Amir Marashi from Tehran came in with some Panorex, and he said, "Would you look at this?" And I said, "Wow, I've never seen anything like that." It was his sister, and her cuspid teeth roots were coming out the bottom of the mandible, and her upper roots were penetrating the floor of the orbit and cutting off their own blood supplies, and they stopped growing. And the other teeth were perhaps a tad bit longer than they should have, but nothing compared to the canine teeth. And she was blind, legally blind, because she had congenital cataract, and then that was treated, and it was followed by increased pressure within the eye, so she had glaucoma. It was really bad, and she also had major congenital heart disease. And so we call this oculofaciocardiodental, right, Eddie? And so that was the first patient. And then you'll notice that the nasal cartilages are a little bit separated, and there's a little dell or a little depression here. Well, here's another patient from the Netherlands that I had occasion to see. A number of them have exotropia, and they have sort of this unusual chin. And, well, this is upside down, but here you can see the cuspid teeth going down here. And here, look at the dell here in the separation. Well, yeah, okay. Yeah, okay, here's another lady. Okay. Okay, well, this is, here's an interesting one. Here we have a patient with one of these. And I remember this is another one. This is another patient, but I'll show you one where there's only one tooth involved. Next, please. Oh, here. Yeah, well, this is, these look pretty bad. And another one. Same one. Okay. Okay, here's another one. Whoop. Yeah. Yeah, this is interesting because there's only one here. Now, everybody I have shown you so far is female. And so we came to the not illogical conclusion this was X-linked dominant lethal in the male. And here we have a male with one of these. So it's some sort of post-zygotic mutation. Now, I knew that I had seen this thing reported, and I went back and looked in Triple O, and I remember that Jim Hayward had described this. So I contacted Jim, and Jim had retired, and I said, Jim, would it be possible to go back and to reach your patient? Yeah, he knew who the patient was. And I said, and find out if the patient is blind and has congenital heart disease. Patient did. Whoops, sorry. And in Bob Vickers' collection of just stuff in drawers, there was this. Yeah, we all have that, right? Well, here you can see one of these that somebody was crazy enough to try to remove. And they also have this, it's called a sandal strap alteration. And they also have very often fusion between toes 2 and 3, and I don't remember, yeah, well, I got one of these here, see? 2 and 3, and then the sandal strap. And here you can see this gene on the X chromosome, and it's at XP21.1. And as I say, this thing is allelic with Lentz microphthalmia. Okay? Is that the end of the slides?
There's a gap, and
Then what do we got in there? Oh, well, the reason I put this in is because one of your members sent me a case. And I think you can probably get a pretty good idea of what this is. They have congenital cataracts. The cataracts dissolve. Oculomandibulodyscephaly, right? And they have this little tiny chin, and they have this beak-like nose. Here's a baby with it, oculomandibulodyscephaly. Here's another baby, and I guess, is there anything else in there? Oh, well, I just put in, because I had a space, I just put in progeria in here. Just show you what progeria looks like. We can go on to the next box. Okay, well, many years ago, I'd say 60s, I had 3 brothers come in to see me. And the 3 brothers also had this paranasal thickening, but they had ears that looked like those of a boxer, and they had severe conductive deafness. Now, I'll show you the other 2 brothers. Here's one brother. There's the other brother. And they had what I called a pugilistic face. Something got stuck again, huh? Okay, now the hands were certainly distinctive. Nothing as distinctive as the feet, but the terminal phalanx of the thumb was flat, and all the rest of the fingers looked flat, and the bones were curvy. Ooh, ooh. Okay, yeah. The toes look like those of a tree frog. And you can see there's a space here, and the rest of the toes either have syndactyly or they're curvy. Wonder why we should be having so much problem.
That's the evil.
Oh, yeah, that's the evil eye, mal di ojo. Contra il malocchio. Right? These individuals all have a mixed deafness. That is both sensory neural and conductive, but it's mostly conductive. And they all have this broadening of the nasal bridge and then the unusual fingers. And so I call this otopalatodigital 1 syndrome. And I didn't know the genetics, because it could have been just old plain recessive. But I didn't know until this sister was born. And she had some of the stigmata. Now, you would have guessed that Mama would have had some of the stigmata, but this is an X-linked condition, and Mama looked perfectly normal. So it was only, now all those boys had cleft palate. And she did not have cleft palate and did not have a lot of the skeletal changes her brothers had. So I was pretty strong on the idea this was X-linked. Okay. So that's where we got at that point. Now, here you can see that we have some unusual carpal bones. Here's a tear-shaped lesser multangular, and here you can see something that's really odd. You can see that the second metatarsal and third metatarsal have fused with the tarsal bones, and these look like oars. And nasion celebasion is normally about 132 degrees, plus or minus 3. Here you can see it's a right angle. So these were really unusual in otopalatodigital syndrome. Then a friend of mine from Canada said, hey, what is this? Now, these kids really had strange bones, so we decided to call the first one OPD1, and this was OPD2. And they had an omphalocele, and let me show you the peculiar, well, this is just another one. And look at this. These are really strange bones that I'll show you in a second. Here is your tibia, here is your fibula, and look at all these bizarre bones that they have. So this was OPD2. And look at the toes in the OPD2. And the face in OPD2. And the toes in OPD2. Yeah, okay. And here you can see in OPD2 the odd bones. So they were really quite distinctive. Okay, so much for OPD2. Then Mike Cohen came in with this guy, and he said, what do you think this guy has? The guy came in because he had a congenital heart problem. And he had this torus of bone up here, and he had a very odd chin, and he had fixation at the elbows, fixation at the knees, fixation at the hips. And then in comes this guy. Now, the fascinating thing about this fella is that he came from Puerto Rico, and I don't know whether it's a custom or just a custom with his family. He had a family portrait of people that died with open caskets. And so it was very easy for us to figure out that this was an X-linked disorder. And we coined the name frontometaphyseal dysplasia. And I'll show you the odd things we have here. Look at this torus of bone. Well, this is the first guy with the fixation at the elbows and the hips and the knees. And here you can see the flat terminal phalanges and the flat thumbs. And you can also see the contractures. And here you can see the keloids, which is also part of the disorder. And here you can see this torus of bone. Now I hope we can see well enough because the mandible comes down and it goes and down and across and then up again. And here you can see this torus. And the eyes have this Byzantine arch to them. And here, I don't know whether we can see this or not because it's upside down, I guess, but it comes up. Yeah, if we can flip that over. Yeah, look at this. It comes down, over, and then up again. So I thought that is really quite specific for this entity. And you can see that there's an odd terminal phalanx, and you can see that the middle phalanges are rounded. And then along comes this gal. Now, she happened to be the sister of a prominent politician. And he was the one that kept bugging us about advancing his sister's mandible. Well, she had interesting changes. No, I think this was not the one. The next one will be. But you notice that she has tori on the outer portion of her eyes, and she had a very specific skeletal alterations. And so we made the diagnosis of Melnick-Needles syndrome on her, largely because it looked as if every rib in her body had been fractured. And of course, none of them had, and nobody would advance her mandible because in the retromolar area, one, there were no coronoid processes, and two, it looked as if it were all fibrous. And I'll tell you what happens to this. This, as you can see, she has a small mandible in Melnick-Needles. This is the sister of the politician, and she has these tori on the outside and a small mandible. And oh, this got out of order. Okay, this is this frontometaphyseal with a fixation at the elbows. Here is Vicky again with a small mandible. And you can see they have bowed legs as part of the phenotype. They also have some degree of exophthalmos. And here is another lady with exophthalmos and a small mandible. And now, I went back, and the thing that bothered me is that Melnick and Needles said that they had a large number of males in their family. And I had never found anybody but a female, and I found an awful lot of families. And so I thought this was X-linked dominant lethal in the male. So I called up Melnick. He's a radiologist in Ohio, maybe Youngstown, I've forgotten. And I introduced myself, and I said, John, would it be possible for you to get me some x-rays on these affected males? And he said, well, I never saw these people. I just took the history from the mother. And so he got a couple of males in, and of course they weren't affected. And I'll show you those corrected pedigrees in a little bit. But I wanted you to see what the skeleton looks like in Melnick-Needles syndrome. And here you can see a good deal of what looks like fractures in the ribs. And you look at the ilia, and they are weird looking, and the femora are very straight, and there's no constriction in the neck. And here, look at this, it just goes straight down, and they're constricted here. And look at how rough the ischium and pubis are. And they really do look as if they were fractured. But this is typical of Melnick-Needles syndrome. And they also have this odd tibia. Now, it turns out that if a Melnick-Needles lady gets pregnant, she can have an abnormal fetus, and the abnormal fetus is always male. So there is a Melnick needles embryopathy, and they don't have thumbs or big toes. Here is the typical humerus for a person with Melnick needles. It looks like a mouse had chewed on it. And here, now look, you can see why these people were not going to mess with the Melnick needle people, because in the retromolar area you have all of this stuff that looks fibrous, and you notice that the coronoid process is not developed. Well, we actually went in to see what we had here, and these were just loculations. They were just indentations. And I don't know whether she ever had anything done. I was curious whether other people didn't have any process up here, and you see they don't have any. And here's another one, no process, no coronoid whatsoever. Whoop, sorry. Well, if you can focus that just a bit, you can see this was Melnick needles pedigree when I corrected it, and all the rest are female. Okay, next please. Hetty. Explain this guy. Yep, Klinefelter. That's what he had. Next please. Here he is. Next please. Next, please. Odd chest. Next, please. Another Klinefelter. Next, please. Now, I wanted to show you the Melnick needle embryopathy. And it's pretty gruesome looking, but they don't have thumbs and they don't have halices. They got this little tiny mouth. And here you can see the bent lower legs and the lack of a big toe. Bent bones. And now, but the only calcification they have in the skull of these embryos is this center of calcification and this center of calcification. Otherwise, the skull was like a paper bag. And this is the foot. You see that this little bone for the hallux is markedly abbreviated. And here there's hardly any thumbs and hardly any big toes. Now, what we did is we got 6 patients with OPD1 and 13 patients with OPD2 and 7 patients with frontometaphyseal and 10 patients with Melnick needle. And we analyzed them for filamin, which is actin-binding protein. Now, it's absolute chance, but my son spent 2 years up at Harvard in 90 to 92 sequencing actin-binding protein or filamin A and B. And he knew, and he published in 1992 or 1993 in Science or one of the other articles, that it was located at XQ28. So we decided that this might be a good place to look, and sure enough, we found the mutation. All these were allelic at XQ28, and I'll show you that in a second. Now, filamin A is actin-binding protein, and it heterodimerizes with the other filamin B. And you see it's a pretty big one, which is why it took him, because he was using RFLIPs, restriction fragment polymorphisms, to map the gene. So it took him a couple years to do that. Of course, now we wouldn't do anything that silly, but you can sequence things a lot faster. And these filaments, they really are part, actin-binding protein is part of the cytoskeleton, and all of these other signal transduction elements are attached to the actin by the actin-binding protein, which is filamin. So here's your skeleton of the cell, if you want to call it that are attached to all of these various genes. So as I say, it's responsible for cell shape, migration, etc. And let me show you what the gene looks like. Well, there is an actin-binding protein at the end of this gene, the so-called calponin homology, and that is up here, and all OPD1 and OPD2 map to that area. And down here, where all of these mutations are located, your Melnick needle syndrome maps, and then the other just sort of scattered around is where the frontometaphyseal syndrome is. So we found mutations in 3 of the group, 10 of the 10, 3 of the frontometaphyseal out of 3, none among the atypical, and 10 in the Melnick needle syndrome. So this means that as far as this actin-binding protein domain, there are some very specific regions for some of these, and let me show you what this all means really. I mentioned it was XQ28. Oh, I'm not going to show you the gene. But it depends upon gain of function or loss of function. Now, let me say that when there is a mutation, and whenever you're changing the function due to a mutation, you either stay neutral, in other words, because of the redundancy of the genetic code, you may get a mutation that doesn't change a damn thing. Or on the other hand, you may get a gain of function, or you may have a loss of function. All of the mutations I've talked about are gain of function mutations. Loss of function mutation you can have due to a lot of things. You can have recessive mutations, which are loss of function due to enzyme defects. You can have haploinsufficiency, where half, your single gene mutated is just not sufficient for function. Or there is also another mechanism that we'll talk about in a second. But with loss of function, another guy at Minnesota, whose name is Bill Dobbins, who was head of pediatric neurology, he found that also actin-binding protein will cause these little lumps in the ventricles. Now, all the ganglion cells start at the ventricles and they move out to the cortex and then they come back again. But in this case, you get this nodular heterotopia, and that is also allelic. In other words, it's a mutation in the same gene. And so what I'm saying is that in this article, which appeared in Nature Genetics just about 1 year ago, we proved that all of these conditions that I had described separately were really all allelic conditions. Okay, now we're going to talk about some more allelic conditions, lip pits. And it's pronounced Vandevoude. That's the correct pronunciation. She's a Dutch lady. And of course, she wasn't the first to describe this. That goes way back to 1840 something or other. But lip pits was actually recognized as having a site on chromosome 1 by Maureen Boshin, who is down in either Davis or Irvine. I've forgotten where she is now. But when she was doing a thesis with Dave Ramoyne, who was at Cedars, she actually did the mapping based on riff lips. But here you see these little things that are easy to recognize. And I mentioned before, I talk about the rule of recurrence. When you studied your oral pathology and your embryology, you learned that cleft lip with or without cleft palate runs in families, and you learn that cleft palate runs in families. And if you have cleft lip with or without cleft palate, you have a greater chance for having a kid with cleft lip with or without cleft palate, but no greater chance for having a kid with cleft palate. And vice versa, if you have cleft palate, you have a greater chance for having a kid with cleft palate, but not for a kid with cleft lip with or without cleft palate. So, long time ago, Fogg Anderson said that these are two separate entities. And he said, you know, one occurs more common in females than males, that is your cleft palate, and the other one more common in males than females. Well, turns out that in many syndromes, that's simply not true. And in Van de Woude syndrome, that certainly is not true. And it is the most common, I suppose, of the cleft syndromes. And here you can see that this patient has lip pits, but they certainly are joined together in the midline, so I don't know what you'd call that, and cleft lip palate. So you get some remarkable variation. What do you call this? I don't know. It is Van de Woude syndrome, but it's a mess. And this is, well, if you look real close, and you have to look real close, you'll see that there are some pits here. Now, this is actually the basis of a lawsuit. And it was a painful lawsuit. Here you can see a patient whose pits were so small that you can stick gutta percha points in them to demonstrate them. But now, embryologically, the mandibular process has 3 invaginations that are temporary. They normally disappear. But you can have a maintenance of your central one, which would cause cleft mandible, or you can have maintenance of the 2 lateral pits to cause Van de Woude syndrome. And here you can see the central pit and the 2 lateral pits, which are evanescent. They just exist for a little bit. Now this fella has 1 central pit and 1 lateral pit, and he had a correction of his cleft lip palate, and he was the proband in the lawsuit. He was told, well, no, chances of having cleft lip is 2% or 3% or whatever it was they told this guy, so forget it. And he sued for hundreds of thousands of dollars and won. This is his daughter, and she had cleft palate and lip pits. Now, again, lip pits, well, lip channels, I guess, would be better. Now, what else do you see here? Attachment between the alveolar process and the upper alveolar process, okay? Now, this is not lip pits. You'll see what it is in a second. And this other person doesn't really have, they have lip pits, but they don't really have Van de Woude syndrome. That's just cleft palate there. What they have is popliteal pterygium syndrome, which also maps to the same area. And this is reported in Nature Genetics as well. And this was the work of Jeff Murray, the senior author. He was the senior author, which means the last author. You notice there's this reverse snobism lately, where the main author that thought it up is the last author, and the first author is the poor guy that actually does it. Well, a guy named Kondo is the first author on this remarkably fine paper, and I wanted to show you attachments between the lower jaw and the upper jaw in popliteal pterygium syndrome. Sometimes they're just little attachments. Okay. Well, sometimes there's a big attachment. Now, here's popliteal pterygium, and there is a fold of skin which attaches from the heels behind the knee up to the ischial tuberosities. And you notice there's something, whoop, I'm sorry, there's something wrong here genitally, right? And she also has the cleft lip palate and the lip pits, but there's something wrong genitally, and we'll show you that as we go along. Here's another guy with popliteal pterygium syndrome. Here is this fold of skin. Now, unfortunately, the sciatic nerve runs right here underneath the free margin. So, and they also have an intercrural pterygium in about 25% of the cases, and the penis is hypoplastic. And here you can see a popliteal pterygium, and I think we have a, yeah, this is really bad. And here you can see from an article of mine where you have this fibrous band that forms the free margin, and the sciatic nerve runs underneath. And I know of a case where the plastic surgeon, in his desire to do a Z-plasty, slotched right through the sciatic nerve, and then got a neurosurgeon to help him out, and then charged the mother for the services of the neurosurgeon. And she was a nurse, and she heard about this. $600,000 later. But that's the story in popliteal pterygium. Now, they also, females also have genital anomalies in which there are no labia majora. And the males very often will have half a scrotum on one leg and one half on the other. So there are all sorts of genital abnormalities. And I thought you'd find this interesting. It was an observation of mine that not uncommonly they have this triangle of skin in the hallux, and sometimes there's a little thread of tissue that goes to the free margin of the nail. And, well, I guess I probably took that other one out, but you can see that they're all, well, ankyloblepharon, attachment of the eyelids, 18%. There is in my book, I think the first entity is clefting with ankyloblepharon. That's just a form of this syndrome with variable expression. And this is where we described, or Jeff Murray described this. And this is an interferon, well, you'll see this in a second. This is an interferon regulatory factor 6. Now, there are a lot of interferon regulatory factors, and a number of them, we don't know what the hell they do, but they do look alike. And a lot of them are involved in other processes, and they all have these transcription factors have various phenotypes, for lack of a better term. Some are zippers, some are zinc finger alterations, some are helix, turn helix, or helix something else, or winged helices. There are lots of names applied to the conformation of these transcription factors. And let me, well, as you see, this should be viral, not vital. Most of these factors are involved where you have viral infections, and they will call forth interferon alpha and interferon beta. But we haven't a clue concerning the function of this specific factor. And as I say, haploinsufficiency of IRF6 disrupts facial development, and dominant negative mutations disturb the development of the skin and genitalia. This so-called loss of function, let me try and explain what dominant negative mutations are in case you haven't had that term. This means that the abnormal product, because of the mutation, interferes with the product of the normal gene. So hence you have loss of function. Okay? That's what dominant negative means. Okay? And here you can see the various anomalies we've talked about in popliteal pterygium syndrome, with the adhesions between the eyelids and the other anomalies, and that pyramidal skin over the hallux. I don't know why. Well, here you can see where the mutations are. There's a protein binding area here on chromosome 1, and here you can see the DNA binding area. Now, if it's in sort of red or orange, that is the popliteal pterygium syndrome. And you can see they're all in the DNA binding area. But the van der Woude are all over the place. See? And there is one popliteal pterygium syndrome down here, actually in an intron, and we don't understand that. Okay, now we come to a different group of disorders. Now, you remember again when you took a little bit of oncology about the oncogene P53? Well, there are a whole schissel full of these things, P63, P73, etc., and it's P63 that's involved in the EEC syndrome and EEC-like syndromes. And let's go over a little bit of that. Here's a kid with EEC syndrome. You see that he has a pigment dilution and his eyes are photophobic, and he has cleft palate. And here's another guy with this. He also has photophobia. There's obstruction of the lacrimal punctule, and they're missing the middle ray of their feet and hands. And sometimes there's a little extra bone that goes crosswise. And let me show you some of these. Here is ectrodactyly of the hands. Here's ectrodactyly of the feet. And these are the ones with the EEC. E is ectrodactyly, E is ectodermal dysplasia, and C is clefting. And here is a mother who has 4 affected kids. So you can already guess that it's a dominant disorder. And this gal has hair that looks like that of a Dynel wig. That's the sort of pigment dilution, and there are alterations in this hair. There's a groove down the side of the hair that you'll see in a number of syndromes that we'll show you about. And here you can see the bizarre teeth. Are they conical? No. But are they narrower at the incisal edge than they are at the cervix? Yes. What sort of tooth is this over here? I don't know. You see, there are many bizarre tooth forms in EEC. And I just say the P63 is a homologue of P53, and either a gain of function or a loss of function by dominant negative effect plays this role and causes the multiple anomalies. Now, it turns out that there are 3 EEC genes, but the one that's important is here. This is your P63 gene. And as I say, there are obstruction of the lacrimal puncti, photophobia, cleft lip, and then all the limb anomalies, and the pigment dilution that I talked about, and the nail dysplasia you'll see in a little bit. And then there are kidney problems and conductive hearing losses and clefts of various types. And here you can see this gene in its many forms. P63 can have missing portions from the front or from the back. Well, that's too small for me to see, so I'm sure it's too small for you to see. And there are lots of EEC-like syndromes. And you know these as Rapp-Hodgkin and ECP and a lot of entities. But let me show you where a number of these are located. because, again, you're dealing with the same gene, and it's just different mutations in the same gene. And here you see your EEC cases, and these are EEC-like cases, like cases, like cases, like cases, like. So what do they look like? Well, some of them have adhesions between the upper and lower eyelids. Here you can see more adhesions between the upper and lower eyelids. And some lose their hair secondary to an inflammatory problem, which you'll see in a second. This is their child with a cleft. And look at the inflammatory process on top of the head. The hair will all fall out and the person will be bald the rest of their days. And here's a little guy who, again, has that hair that looks like that of a Dynel wig. And I wanted to show you this groove that they have that makes for this hair. Look at the nails. Now, whether you call this Hay-Wells or whether you call it ankyloblepharon ectodermal flicky-dicky is up to you, but it is nothing but a mutation in the P63 gene, this oncogene. Here's another patient with a hypoplastic or dystrophic nails, just another one. And so you get this Rapp, Hodgkin, Hay-Wells. If they have attachments between the upper and lower eyelid, it becomes the AEC. If they don't, you give it a different name. You know, it's pointless. These are all P63 gene mutations. And I've made up this little diagram. This all stands for something or other, and then T is for tooth. And lacrimo-auriculo-dentodigital, et cetera, and then Rapp, Hodgkins, and Hay-Wells, and ECP. They all overlap one another. And this in diagram is just what I'm talking about. Most of the EEC syndromes occur in the DNA binding area, and in the protein binding area, most of your AEC syndromes, the A being the ankyloblepharon. Well, I'm not going to go over that. Okay, now, a long time ago, when I first got to Minnesota, I saw a lot of patients with Stickler syndrome. And Stickler syndrome was characterized by having not glasses with a diopter of 3 or 4 correction, but a diopter of like 12 to 20 correction. And so they looked like they were looking through the bottom of Coke bottles. And these individuals will have a mild spondylo epiphyseal dysplasia of bone that I'll show you in a little bit, but they have cleft palate with high frequency. And this is a type 2 collagenopathy. And here's another fellow who's had retinal detachment because it's a matter of vitreous syneresis. If you have, well, it's like Jell-O. If you let Jell-O gel, it creeps up on the side of your container. But if it remains in the gel state, in the sol state rather than the gel state, it will occupy less space. Well, occupying less space causes less pressure against the retina, hence retinal detachment. And that's the whole basis for this aspect of Stickler syndrome. And here you can see in this fundoscopic exam the early rip. You can also see these cataracts that they have in the early stage of the disease. And about 15, 20%, sometimes 25% in your series will have a arthropathy, and that is what it is. It's an inflammation and enlargement of the knees and the elbows. And here you can see the the head of the femur, the capital femoral epiphysis, is gone, and it's nearly gone over here. So they wind up shuffling around or getting artificial hips, and the lower part of the tibia is ramped, which is also characteristic of the disorder. And here you can see the high myopia, you can see the retinal detachments and the cataract, and most of them have cleft palate. Now, there is a non-ocular stickler, and I wanted to show you that because this maps to a different chromosome, and it's collagen 11A2. Now, there are two forms of simple stickler, that is a type 2 collagen and a type 11A collagen, but both of those are in the eyes, in the vitreous. A2 is not in the vitreous, so this is known as non-ocular sticklers. And yeah, type 1 and type 2. And can you tell them apart? Well, maybe if you're pretty smart and a good eye guy, you can. But your type 1 here is on chromosome 12, and it's collagen type 2, I said. And type 2 stickler is collagen 11A1. And actually, you can tell a little bit about the difference between the types, but I thought I'd show you a non-ocular stickler. The fella has a very depressed nasal bridge, and he has an odd physical phenotype. Okay. We go on to another slide box. Where are we on the slide box?
This is 10.
10, wow. Really is 10. I have no more after that?
No, unbelievable.
Woo, wait a minute. Yeah. Okay, well, we'll run through this. This is Larsen syndrome. Larsen syndrome is characterized by cleft palate, and they have multiple dislocations. They have club feet. Here he is, dislocated at the elbows. Okay, well, that's fine, yeah. Okay. Okay. Okay, here you can see that he has a depressed nasal bridge. Here's his mama. And what you're seeing here is an extra bone that is juxtacalcaneal. And when that fuses with the calcaneus, it always leaves a little notch up here. And yeah, see, this comes from the heady scene. You were there when this guy came through. And they don't have any carpal bones. And then when they do get carpal bones, well, they also have a lot of flexure creases where there are no flexions, right? You got them all over the place there. And I want to show you supernumerary carpal bones. They probably have 20 plus. Well, okay, ligamentous laxi, that's certainly obvious. Yeah, you can see the dislocations. And dislocations, look at where this is located rather than here. And look at all the carpal bones, but I wanted to show you other. Yeah, look at all these. Oodles of carpal bones. Now this is a little odd too, this terminal phalanx of the thumb, but they also have scoliosis with Larsen syndrome. And oh man, look at that neck. I am amazed that the person's not dead. Here's another one. You can see that doesn't look so healthy either. Now, this is Philemon 2, and in the very last issue of Nature Genetics, the group at Cedars-Sinai turned out 4 disorders that map to this area. And one of them is Larson syndrome, and one of them is an entity that I described called spondylocarpotarsal synostosis. All of these have cleft palate. And in spondylocarpotarsal, or congenital synspondylism, they all have cleft palate and flat feet, and they got sort of a round face. But let me show you some of the, here's some sisters with this. They have scoliosis. And here, look, see, you got a fusion of bones, and the capitate will ultimately fuse with a hamate. So there are lots of peculiar fusions. And there's a curved little finger. But I wanted to show you the spine. There is a fusion on one side which will produce the scoliosis. Yeah, look at this. Crazy looking fusion. So hence spondylocarpotarsal dysplasia. Yeah, look at this. See, on one side. Just another odd fusion. Look at the capitate and hamate fused. And here again, these are fused, these are fused. So they're really quite specific in this syndrome. They have cleft palate. Now, atrial osteogeneses are lethal disorders, and I didn't think that you would ever see these, but they have they don't have the ends of the long bones formed. And I'll just show you a little bit of this. They have odd digits. But look, atrial osteogenesis, no end, atrial, right? Osteogenesis. Okay, now I wanted to show you as my maybe final or almost final thing, a little bit about treacle. Because treacle is the gene that Mike Dixon and Ethelyn Jabs down at Johns Hopkins. Mike Dixon is in Manchester, England, and he and Thakar, Nayland Thakar, are partners. And they isolated with his wife Jill Dixon treacle. Now, the phenotype in Treacher-Collins is so well known to you that there's little point in reviewing it very much, except point out a few things. And here you can see the coloboma in the outer third of the lower lid and the lack of eyelashes medial to the coloboma. But I wanted to show you this family because it teaches us a lot. Now, this woman's husband is quite normal, and I assure you that her husband is the father of her kids. And she has a very mild form of Treacher-Collins syndrome, and her daughter has a little bit more severe form of Treacher-Collins syndrome. And there is the baby. Now, this will really separate the women from the girls, as they say, figuring this one out. It's a toughie. What do you think? As we do it? Pardon? No. It's their other baby. It's their other baby. It's homozygosity for the Treacher-Collins gene. Now, how did it get that way? Uniparental disomy. In other words, it didn't separate, so the person got a double dose of the bad number. See? Now, the question is, does this gal have Treacher-Collins? You notice she has one down slanting palpebral fissure and one normal. Well, let me tell you that her father had typical Treacher-Collins, and so does her child. So this shows the variable expression of the treacle gene. And, well, I'm not going to diddle with that. Well, here's your treacle gene, okay? Now, the treacle gene is about 25 exons long, and in every exon you can have mutations. And well, that's, that's all description of Treacher Collins. You don't need any of that. You don't need this. But here I say 25 coding exons. Most are in exon 24, but there are at least 120 mutations known, and they're all over the place, as you can see. So that's a little bit about treacle. And I'm not going to drive you crazy with that. And you all know what this is, right? Yeah. Pardon? Oh, okay. This is oral, facial, digital, now one. And this is the daughter. And this is, I almost got killed from this case. I went down to see the family, and they were located down in southwestern Minnesota, and I had a little Volkswagen Bug, and I pulled up finally in their farmyard, and the next thing I knew, there was a shotgun sticking through the window, and the mother then came out of the house and grabbed this guy by the ear and took him away. And the kid ultimately wound up burnt up in a barnyard fire. But this is when I described the thing in the 1960s, and you can see why the middle of the lip doesn't come down, and there is back there a cleft palate. And the tongue with several lobes, and these are hamartomas, and here's a trilobe tongue, and here's a quadrilobe tongue, and here, I don't know how many lobes that one has. And here you can see that the frenula are hyperplastic on the sides. Here's a cleft of some sort. And here again, this anterior segment is sort of in the bicuspid area, so that's due to hyperplastic frenulae. And the hands are abnormal, so that's OFD1. And sometimes fingers are missing, and sometimes there's replication of the hallux, and this is an X-linked dominant lethal in the male, and we got that mapped. And here you can see the bone is truly strange. And they also have milia, little tiny cysts in the skin of the face or of the ear. And here you can see all these little milia scattered around. They disappear with time, and they die usually of kidney failure due to late onset polycystic disease of the kidney. And here you can see X-linked dominant lethal in the male. And do we have any other slides in there? Or just
We had 7 more.
7 more. Well, okay, I'll just tell you what this is. This is cleft palate associated with hypotelorism. And that's a dominant disorder, and I think we got some other pictures. Yeah, see them. They all look pretty much the same. Well, I thought I had brought with me something which I obviously didn't, or it's in one of the other slide boxes. And I thought I'd tell you a little bit about that because it's so weird. A woman calls up and she says, "Do I have the right number?" Well, I don't know. So what is it you like? Well, genetics. I said, well, you may be calling the right number, maybe you're not. What genetics is it you're interested in? Well, teeth. I said, maybe. So she said, what do you have where you have absolutely no enamel and you have unerupted teeth? And I said, well, yeah, I do have a syndrome for that. And I said, you know where the dental school is? Well, I come there all the time. I said, you do? Well, what's the name of your student? Oh, I don't see students. I see department chairs. So, okay. When are you coming in? Well, Tuesday. I said, well, here's my beeper number. I gave her my beeper number. So she comes into the private practice thing with her daughter, and they're sitting there in the room, the daughter's sitting in the chair, and around the room they have a whole mess of view boxes, and they had a lot of panorexes. And I looked, yeah, there's no enamel, and the teeth aren't erupting. And I said to the gal sitting in the chair, what is there about you that makes you you? And she says, that's simple. Shows me her nails. And I said, my God, you come from St. Paul. Now, she didn't have any attachment between the nail and the nail bed. This is called onycholysis. And I'd seen a whole family with Carl Whitkop and a gal named Louise Messer that you remember. And it might have been John Salk. I don't remember who the other person was, but it might have been. And so I said, well, it has to be. And she said, well, why do you say that? And I said, well, I saw this family way back then, and they came from St. Paul. I think all their relatives came from St. Paul. Absolutely, you're wrong. And I said, why is that? Well, we're into family pedigrees. And she says, nobody in our family, and we're down back 7 generations, ever come to the dental school. And I said, okay. She says, do you know the name? Oh, no, I don't know the name, but it's possible. So I came up, and you know how we used to fold those slides, right? I looked on the inside, and it gives me the name of the family that Carl had seen. And so I went down, I gave her the name, no relation. I said, well, that's really very unlikely. So I got the DNA, and we sent it to, we had looked around. I figured this is bound to be a connexin disorder or a keratin disorder. And so we sent it to the best person I could think of, who was Angela Cristiano at Columbia, because she's into both keratins and connexins. Not so far discovered. But I now am in the process of trying to locate Carl's family, so maybe we'll have better luck. But an even stranger story, a guy comes in who had attempted suicide. And he says, well, the reason I tried suicide was because I'm an architect. And he said, I can't use my right hand anymore. And he said, I already got lumps on my left side, and somebody said I have neurofibromatosis, and I have the same thing my mother has, and that is Schwann cell tumors all over the place. And I said, well, where are these? Well, they're all over. I said, well, that's not NF. I don't know what you got. And I said, I know it's a dental school, but would you mind stripping down to your skivvies? What are you looking for? I don't know. Well, the minute he takes off his shirt, I see he's got maybe 100 strange lesions on his skin. And I said, what's that? Oh, it's the family mark. And I said, family mark? Now, what is that? You got 2 different types of lesions. Well, yeah, we do. I said, anybody ever take any of them off? No. I said, do you mind if I take off a couple, 1 of each? No. So I said, okay, we'll do it on your back. So we took it, and they turned out, the dark ones, turned out to be Clark nevi. So I, wow, that's interesting. What else runs in your family? He said, I don't know. He said, my mother, now she's coming here because she knew I tried to kill myself, she said. So she's coming here over the weekend, but she and my sister have something they don't want to talk about. And I said, genital? He said, I don't know. And I said, okay, would you bring Mama in? So in comes Mama. And I said to him, okay, stay outside while I talk to Mama. So I said to Mama, I know it's a dental school, but would you mind stripping down to your bra and panties? She says, oh, you're interested in the family mark. Yeah, I want to see the family mark. So sure enough, she had the family mark. And it turned out he had managed to impregnate a lady over in Wisconsin and had a baby with a family mark. He had a brother with a family mark. And I said to Mama, now where did you get it from? Well, she says, I think I got it from my father, but he killed himself due to financial problems. And I said, well, was he from? Well, he was from Montana, Idaho. So I said, well, do you ever hear from his relatives? Oh, they thought the suicide was our fault, so they stopped writing to us. I said, do you think you could locate them at their last address by Christmas cards or something? So she went up in her attic, found old Christmas cards. I got 2 more cases that way. And then finally, I wasn't able to figure out what this was. So I figured, well, I'll get, oh yeah, you want to know what the stuff was in the vagina. In the upper vagina, there were some grape-like botryoid leiomyomas. And of course, the upper vagina embryologically is the same as the uterus and tube, so it's Müllerian. And microscopically, they look like leiomyomas. So John Koutlis and I wrote this up, and we published it in American Journal of Medical Genetics. Well, next thing I know, I get an email from a gal from London who was originally Bangladeshi, and she says to me, I have the gene for leiomyomas of the skin, you know, the rectores palorum, and uterine leiomyomas. And she said, can I have some of your DNA? I said, sure, but I sent it all to New York. And she said, well, how can I reach them? I gave her the number. Well, the first thing she did is tick them off because she wouldn't tell them where her gene was. So every month I get an email from her. And finally she says, do you think you could hit up your proband again? So I did. I called him up and I said, can I get another sample? Because we want to immortalize the cells, you know. So, yeah. So you get a yellow top tube for that. So we got some more blue top, purple top tubes and yellow top tubes. And I sent it to her. And then I said, you know Afrina alam, Afrina, your combination is associated with kidney cancer. And she said, how'd you find that out? She said, I thought that everybody was sworn to secrecy. And I said, I figured that out. And I said, look, what do you know about this? And she said, well, I shouldn't tell you this, but she said that's how we got into trouble in the first place. She said, yes, the kidney cancer is part of this, and she said it maps to 1q42, which is where everything maps to. I said, well, you got 2 of my samples. How about checking it out? So she did, and it is.